going to speak on autoimmune dementia, diagnosis and treatment of it.
Thank you. Sorry for the problems. I hope I was able to convey whatever.
So, a very good morning, and I'm very grateful to the organizers, to Sanjay Sharma, Nachiket Dikshit, and everybody for inviting me here today. I think this talk will take off from where Dr. Pujari left it, and then it will also lead into Manjari's talk after this. But I also think that what I'm going to say is literally what probably most of you know very well. But it's also important because the topic is about treating dementias that are conventionally thought not to be treatable in majority of cases. We are at a time, I think when the topic was suggested, we did not know that Alzheimer's disease was going to have a treatment a few months ago. But now we know that even Alzheimer's disease is going to have a treatment, and it's going to be immune modulation. And so we are at a very exciting time in dementia and cognitive disorders where treatments actually seem possible. But the challenges are, given the complexity of their pathophysiology and the number of mechanisms by which cognition can get affected due to brain disease, the challenge is going to be that we diagnose people as early as possible. And I was talking to Manjari, and she's doing some amazing work on stigma in epilepsy. So I thought that I must, still dementia as a disease is stigmatized, and we don't make a diagnosis early. And in this era of immunology and dementia, we are losing an opportunity if we don't diagnose them early. But the other challenge is that we have to be as specific as possible, because one treatment won't work for if you treat it in the wrong pathology. So we also have to be as specific as possible. And again, we know that the numbers of people with dementia are really increasing, and in our clinical practice, we're just seeing more and more and more. While amyloid, tau, TDP, all of them are pathologies, vascular, the new entrant to this is autoimmune disease, and which is adding to the complexity. The word is inflammaging. So as we age, inflammation increases in the brain. So we're also susceptible to changes due to inflammatory disorders. We heard about MS mimics causing cognitive problems, and therefore this is also a very young disease. It's only in the last 15 years, I think, that we have started seeing patients where we are diagnosing autoimmune encephalitis, for instance. This is a very typical case of NMDA encephalitis with the 2-month history of seizures, behavioral disturbances, memory disturbances, NMDA positive, EEG showing delta brush pattern, bilateral medial temporal hyperintensities. We know that this is autoimmune encephalitis. We treat and the patient gets better. But if you follow them up, many of them still have some kind of inattention, working memory problems. They're not fully functional cognitively. But even then, that's relatively easy to diagnose now. I'd like to bring your attention to this 51-year-old lady who had a 5-year history of behavioral problems, fear, panic attacks, memory disturbances, and then she developed visuospatial and language disturbances. Now, typically in cognitive neurology, you trace the pathology. So that's something that's starting in the medial temporal lobes and then spreading to the lateral temporal parietal. Teaching is that it's Alzheimer's disease. So she was following that kind of a pattern, but she also had anxiety, restlessness, insomnia, and she had global cognitive decline. Her imaging showed atrophy, medial temporal atrophy, hippocampal volume loss, And therefore, the different diagnosis was Alzheimer's dementia. She was started on donepezil, memantine. But when you're running a cognitive disorders clinic, you are working with some very bright people and neurology residents who want to treat. So pick up some atypical features, a lot of episodic fear and panic attacks and sleep disturbances. So we investigated for other causes and we found that her serum and CSF were positive for NMDA. And this we called at that time dementia, but due to NMDA encephalitis. But then if you look at the diagnosis for autoimmune encephalitis, typically you make the exclusion is more than 3 months. The criteria say that you have to have a disease that is just about for 3 months. But this lady had a long duration and she had global cognitive decline. MRI did not show hyperintensities, EEG did not show delta brush, CSF there was no pleocytosis. So this was atypical for autoimmune encephalitis also. But because CSF NMDA is fairly specific, we treated her with methylprednisolone plasmapheresis. It takes a lot of courage to go on with the treatment in a person who has just atrophy. And you wonder, is this a false positive result? But 6 cycles, I must say, Saraswati, the girl who was assistant professor, she works with me, very intent on treating. And then as a thioprin, and we saw a significant improvement in cognitive scores and improvement in all that anxiety and panic attacks. She used to feel that the knee hammer was a dagger that the resident was coming towards her with. And when she came back, it improved. And I showed her the knee hammer. She said, I remember that was looking so, threatening to me, but I think I had some kind of, something possessed me, but now I'm fine. So this is a chronic presentation of autoimmune encephalitis. This gentleman was a surgeon, he was a professor of surgery, and he had insidious onset of behavioral disturbances, apathy, sadness, irritability, some forgetfulness, but very specifically had disinhibition, over-familiarity. So general behavioral problems, we don't think of degenerative frontotemporal dementia, but when somebody has disinhibition, over-familiarity, then you start thinking this is an orbitofrontal pathologies that usually are, TDP or tau. So the referent diagnosis was behavioral variant frontotemporal dementia. But then again, you go back to the history, severe, she had episodic depression, some fluctuations, intermittently the disease would progress a little rapidly, there was no family history, and no improvement with any kind of behavioral therapy. You can see here that the delayed recall, he could remember no words of the 5 or 6 that he had learned, and that clock is just showing significant perseveration. It's just drawing that one minute line again and again, over and over. But again, no movement disorders, no seizures. Serum GAD was positive, CSF GAD was negative. Now, this is again something that you come across in the clinic, and in the OPD, patient is looking like he has a frontotemporal dementia, but certain features were odd if you look back in retrospect. And then this patient, the MRI showing mild temporal PET is showing mild temporal hypometabolism with atrophy, nothing very specific. So then we started calling this autoimmune dementia with a neurodegeneration-like illness due to anti-GAD antibodies. Again treated with IV methylprednisolone, mycophenolate. You can see the clock itself demonstrates from that perseveration to an absolutely fine 10 minutes past 5 and remembered 6 or 7 words, recall. But this is dramatic, this kind of an improvement. And then you go back to the clinical course. I'm just meeting all my NIMHANS friends here, and this I learned from Manjari. Trace the course in the dementia patients. So Mr. Nachiket is here. We long stories about how the disease started, what happened every 2 months, 3 months. It seemed pointless after a while in a degenerative disease, but that experience and that practice and discipline really helps us understand our diseases better. You can say episodic depression, then behavioral disturbances, then memory, coming and go. Somewhat, rapidly, then you start treatment better. Again, the person stops treatment because the improvement is there, such a dramatic improvement, still compliance is not good. It's a chronic therapy, relapsed, again restarted, and my patient improved. So this is GAD antibody, anti-GAD antibody syndrome. We've heard about the other features that they can have. They may not have them. So the current criteria which for autoimmune encephalitis clearly mentioned that it has to be less than 3 months, CSF pleocytosis and all of that. But I'm sure none of us really follows this criteria and they are still evolving. But it is difficult to make a diagnosis when you have so many atypical features. We wonder, is it autoimmune? Is it an autoimmune disorder or is it neurodegeneration? And it's so important because the treatments are very different. And misdiagnosis is common. And sometimes it's only the trial of immunotherapy that proves diagnostic one way or the other, is what we thought. And therefore, you will hear from Manjari about the more acute presentations, and these are the more chronic presentations. And it's a spectrum in a brain that is also very different. Young, healthy brain, older brain with some pathology. We know Alzheimer's disease starts 15 years before vascular disease starts. So we're talking about brain health here when you don't know how many pathologies are there over which there is inflammation and how much response to treatment or not. And I think this is what makes clinical neurology so exciting for all of us. So when you make a diagnosis of autoimmune dementia, it could be that a person has an episode of autoimmune encephalitis and then kind of worsens or stays status quo, that is autoimmune dementia due to autoimmune encephalitis. And or there can be a smoldering, ongoing chronic inflammation which suddenly gets worse, and that is autoimmune dementia. And this is Justin Long, who spent a lot of time trying to understand this with many people across the world. So the chronic presentations are fairly well established that they occur. Now this is another lady who had forgetfulness for 9 years, misplacing objects. And then she developed language problems, difficulty in remembering names, and then neglect on one side of the body. And some slowing of gait with neglect on the, and some apraxia as well with the family history. So you're getting a very long history, family history, and asymmetric cortico-basal kind of a syndrome. Casper is positive in her. And then you can see that it just again shows atrophy, but you can see in 4 years that atrophy has progressed so much. And at 4 years back, again, there was no diagnosis of autoimmune disorder. So this is a patient who came recently to us. We started her on methylprednisolone, plasmapheresis, some improvement, but we are still now going to continue treating her, and sometimes they don't always improve. So the current nosology, you have autoimmune encephalitis, autoimmune dementia where there are chronic presentations, and then you have these atypical forms where it's positive, the antibody, but they also have a picture like a degenerative dementia, and a third variety where it's clearly a neurodegenerative dementia. And the closer you go to neurodegenerative side of the spectrum, the less evidence of inflammation you have. But it's important to recognize this entity because early treatment definitely indicates a better cognitive outcome, and a third of them are falsely diagnosed. So how common is this really? In early onset dementias, it's about 5% in the current series. So we thought, and it could be both surface antigens and intracellular antigens. And you can see that surface antigen related autoimmune encephalitis, majority have cognitive problems, 90 to 100% have them. More neuronal antibody syndromes, yes, but to a lesser extent. So we looked at, I think, 1.5 years data of 306 patients, and this number has grown since. This was during COVID that we looked at it. We had about 10% nearly, in a specialist cognitive disorders clinic, we make a diagnosis of autoimmune dementia. Again, the age is 55 years. Typically, degenerative dementia is about 60, 65. But the median duration was 3 months to 84 months in many of them. So mostly had a chronic progressive course or a chronic relapsing or rapidly progressing. None of them had a classical neurodegenerative disorder spectrum. Now we know. So when you look at them, this is not looking like Alzheimer's disease is what our residents say, not a typical FTD. So we are not making so many misdiagnoses, but imaging is only showing hyperintensities in about 40% maybe, and several times normal as well. And the entire spectrum, LG1, TPO, NMDA, GAD, Casper, we are picking up many other antibodies. So this is where we diagnose autoimmune dementia, young onset, subacute course in between, panic attacks, sleep disturbances. Dr. Chandra, who was working with us, has a nice publication on this triad of sleep, panic with autoimmune encephalitis, and there could be autoimmunity. And there are several methods. I won't go into all of that. You have to rule out other causes as well. But then the number of antibodies increasing is so much. Every year we are hearing about new antibodies. So seronegative autoimmune dementias is also a common diagnosis now. We want to go back and look at them. So how do we treat them in the acute phase? Currently the management is like any other autoimmune encephalitis, but for a longer period, and assess them because there's a risk of secondary infection and all of that. Now, do they respond to treatment? Case-wise, yes, but overall, how? So I'd like to just spend some time with our, I will go fast, yeah. So the patients that we had, we did both short-term and long-term outcomes. Short-term outcome within 3 months, that is that they come into the clinic, we're actually looking at them, 75% responded very much to immunotherapy. Then we followed them up over literally 4 years, in some cases 5 years, but a median of 2 years. And in that you can see that nearly 50% continued to have mild to moderate treatment, and 50% had significant improvement. This is on a telephonic follow-up of clinical dementia rating scale. So there is a notable improvement despite the fact that they came late to us. So the prognosis was good in this group of people, not all of them, but about 2/3 of them. This is a small bias. I'm sure each of us has our own experiences with this. Cell surface targets better than neuronal intracellular antibody-related syndromes. To conclude, this is a disorder that is important not to miss really. And the diagnostic clues are generally there. There are these atypical, if once you know degenerative dementias, we are now saying, okay, this is not looking typically degenerative. There are panic attacks, fearfulness, insomnia, psychiatric disturbances. The cognitive disorder is not like a typical neurodegenerative dementia, but then you don't get CSF bibliocytosis and all of that. And treatment, you have to persist for a few months and then you get some response to treatment. With that, I'd like to thank all the team that's actually working on this at NIMHANS and the patients we see. Thank you.
Thank you, ma'am. Dr. Manjeet Tripathi, ma'am, from AIMS Delhi, to present. Thanks.
ये दोनों लगाना पड़ेगा। हाँ।
Very good morning to all of you, and I'd like to thank Dr. Sanjay and Dr. Nachiket and team for having me here. And it's wonderful to be in Raipur, and we discovered that we have a close relative of ours here, so we visited them yesterday. I thank the chairpersons, and actually my talk has been made easier because Dr. Pujari and Dr. Suvarna have really dealt with quite a lot of the autoimmune phenomenon in the brain. Is it going to project? So I'm not going to be talking about the cognitive issues, nor am I going to be talking about the MOGAD spectrum. If I have time, I'll be showing some cases, and it still doesn't show up there. Do you have to press something here? Function key or something? यहाँ कुछ करना है इसमें? हाँ, the cable is connected. There are two. He's connected one. I'm sorry, but I had some videos which I will show depending on the amount of time available.
कन्वर्टर को
There seems to be some technical issues which have cropped up. I did check it out in the morning. Is it there? Oh gosh. I can just transfer the talk without the videos. So. I can just do the talk without the videos. I can transfer it on the pen drive and the next speaker can come up if need be. Who's the next speaker? Okay, great. So we'll start off, and my job has been made easy, as I said. I'll be talking about the terminology, the categories, and there it goes off again. There seems to be a problem. May I know who the next speaker is? Could you know the next speaker? Yeah, we could transfer without the videos and can we move on to the next speaker for the timing? Sorry for this.
Dr. CM Singh, are you around?
Sir, I invite.
In the meanwhile, we can start our question and answer session. So, all the chairperson.
Okay, ma'am.
I managed to transfer it fast without the videos, and I'm back again. Let's see my luck this time. ये कहाँ लगेगा? There's something here.
लेजर वाला लगा है पर वो तो तेरे इससे तेरा भी नहीं लग रहा है ना हो गया
I don't know. Visuals.
अब हो गया अच्छा कॉपी का है वो ओपन कर लीजिए डेस्कटॉप पे रखो वो उससे नहीं लेगा ना तो मेरे जैसा आएगा कॉपी पेस्ट
Okay, let's see this. If there are any questions for the previous speakers, copy. Okay. Okay. Is it come? Okay. So, we'll be talking about autoimmune epilepsies and encephalitis without the videos, and let's hope this time it projects. Is the projection there? Or am I jinxed? Project ho raha hai? Audio visual? There seems to be some problem. What is the issue? Could you detect what the issue is, Dr. Pujari? They're still unable to. This is their laptop. Now it's come. Let's hope it stays. So I have a talk here without the video, so please bear with me. And we just go through it based on various, subsections. We know this landmark paper, which came out in 2016 by Graw, and it clearly mentions, okay, what is happening here now? Why is this coming up like this? Okay, whatever, let me just go on. So basically, you have to have a rapid progression of symptoms, which is less than 3 months, to be working towards a diagnosis. However, in the Indian scenario, this may not be so, because many patients come to us very, very late. So really you can't stand by those 3 months of symptoms. Wherever you have an abrupt onset of symptoms with high fluctuations, with clustering of seizure syndrome, seizure complex semiology, you could think of autoimmune process. The imaging may be normal but may show bilateral changes, very often bilateral hippocampal changes. And the CSF will show pleocytosis, at least in the acute phase, with the EEG showing certain changes in as high as 30 to 60% of them. And you should have ruled out, possibility of a herpes or say a lymphoma, which is there, or neuroinfection, which could be underlying. But then that is for the definite category where the antibodies would come out positive. There is a possible category, and many of us manage patients on this possible category, in that the symptoms again are of less than 3 months, and you have the same focal symptoms and signs, and you have changes in the CSF as well as imaging. But however, you require only 3 of the criteria, not all 4 of the criteria, and often antibodies are negative in these patients, or you may get one positive. You may get the serum positive or the CSF negative, particularly in NMDA. Or you may get, you may be in a scenario where you've sent it out for testing and you still are waiting for the reports. There you would categorize them as a possible autoimmune encephalitis. Now, we were the first in this country to have a series of our patients, which was published way back, in 2013. So this was the first series from India, where we found a conglomeration of our cases which had a high index of suspicion based on clustering of features and acute onset, cognitive, movement disorders, seizures, dementia, all thrown in together in some of them or all of them. And very often, majority of our patients, about 35% of our patients, had a coexisting autoimmune process. So either they had a thyroid issue, or they had diabetes, or they had positivity of the ANA, but not the full-blown, SLE picture. And these were patients who presented to us with clustering of seizures, with rapidly progressive dementia. So the rapidly progressive dementias, the seizures were, mostly FPD type. We had patients with drops as well as tonic, and they responded very well to immunotherapy. In this series, we lost one patient who came in really very late and had an NMDA receptor encephalitis. not to mention, so ever since, this whole topic has been discussed, there is a tendency to run and diagnose autoimmune disorders. And so this very interesting paper looked at the overdiagnosis of autoimmune encephalitis, which was published in 2023. It's just hot off the press, where they reviewed 393 adults, and of these 393 which had got lumped with a diagnosis of autoimmune encephalitis, actually 27% did not have autoimmune encephalitis. So that is something you really need to be careful about, dumping or lumping a diagnosis and saying that this is autoimmune because of over-interpretation or putting everything as a possible autoimmune encephalitis. So the over-interpretation of positive serum antibodies was seen in 50% of these patients who were negative. And this results from weak titers. So, TPO being weak and you make a diagnosis of Hashimoto's, or even the VGKC being very, very minuscule in amount, and then you make a diagnosis of a VGKC antibody syndrome. And 38% of them were due to misinterpretation. They actually had a psychiatric disorder or a non-specific cognitive issue which got misdiagnosed as an autoimmune process. So there have to be a clear difference between, the immune processes, whether they are the surface antigens or intracellular, because if you have intracellular antibodies like the GAD, the responsiveness to therapy is poor. So it's very important for us to understand this. Now the slides are changing on their own. I have no idea why they're doing that, but just bear with me. I will focus my talk more on epilepsies because the previous speakers have dealt with the autoimmune process in details. We know the definition of epilepsy is 2 or more unprovoked seizures, and the ILE 2017 has introduced the autoimmune etiology for epilepsy. So is it true that epilepsy is actually autoimmune in a significant amount? We'll go through that. But the epilepsies associated with antibodies have been, shifting in their spectrum. As you can see, there's a huge variation of the antibodies you could get. You can get antibodies which are intracellular, and most of the paraneoplastic antibodies would be intracellular, and you could get surface antibodies to surface antigens. The good thing about the surface antigens is that they are easier to diagnose and much more rewarding to treat. So we've had patients who've presented with DPPX, with GABA-A, with NMDA, Casper, all these diagnosed in our series. Now, how do people with seizures and epilepsy present with an autoimmune process? I don't know why this is so fluctuant, but I think I'll be very, very still. So maybe it will not go off then. The whole thing is moving. So you can have an acute symptomatic seizure, which could be a presentation of autoimmune encephalitis, and there it's not epilepsy. So you should not use the term in an acute process with seizures. And the clues to the diagnosis for an autoimmune epilepsy would be the onset with status epilepticus, particularly new onset refractory status epilepticus like NORS or FIRES, pharmacoresistance to 2 or more drugs, associated cognitive decline, which is of rapid onset, a young onset, and association with the known autoimmune disorder. The EEG, of course, showing the delta brush, which we all look for, and of course, various findings in the MRI. This is by Gaspard et al. And you can have these patients go on to a more chronic phase where there is a neuronal death set in by the cytotoxic T cells, and this results in chronic kind of phase of chronic epilepsy. So basically you have to differentiate acute symptomatic seizures due to an acute autoimmune epilepsy and chronic epilepsy, because the prognosis would be different in all of them. So if you have a chronic epilepsy which is autoimmune, you're going to have recurrent seizures. They're usually more difficult to treat, and their responsiveness is poor as compared to acute symptomatic seizure with acute symptomatic epilepsy due to autoimmune process, which is easier to treat. So if you look at the phenomenon of seizures associated, again this is a 2021 paper by Krishna who's worked a lot in Rasmussen's encephalitis, where they looked at 39 patients. They found that most acute symptomatic seizures produced by autoimmune process are due to surface antigens. So that is why we should not miss them, because the treatment is very rewarding. Whereas those which are due to intracellular antigens, and you can see here in the graph, the intracellular antibodies, virtually none of them could go off the anti-seizure medicines. So if you have intracellular antibodies to intracellular antigens, you are going to have people who are going to remain on anti-seizure medicines. Anti-seizure medicine is the blue line, so they are going to be on treatment for long. Whereas the surface antibodies, their ASMs, it is possible to stop their ASMs after a period of time. So that is the most important difference. As I told you, the pathophysiologically also there is a huge difference between intracellular and cell surface. You can see here by Dalmau's paper, where there are cell surface antigens, you have a relative preservation of the hippocampi and the cell body. The cell body does seem to be affected because the antibodies are towards surface antigen. Wherever you have an intracellular antigen, the process is more toxic. There is lysis of the cell and virtually you are left with nothing but the nucleus. So it is much more severe and much more difficult to manage, that is why. So that was acute symptomatic seizure with autoimmune encephalitis. But you can get chronic epilepsy, and that is why the league has put autoimmune process as a cause of etiology of epilepsy. And the kind of seizures you get in chronic epilepsy which are due to an autoimmune process are usually having a perisylvian semiology. So they can have frank motor features, they can have perioral features, they can have limbic features with emotion involved, piloerection involved, autonomic features involved. So perisylvian semiology is more characteristic of the chronic epilepsies due to autoimmune origin. So wherever you find a perisylvian semiology which is chronic and you're finding nothing on the investigations except some perisylvian atrophy, perinsular atrophy, think of chronic epilepsy associated with autoimmunity. There are some scores to help you out, and these scores should be available to us bedside. We usually ask our residents to chart the score whenever we are suspecting. The first is the APE2 score, and this is very, very easy. APE score of greater than 4 is usually seen in patients with epilepsy with unknown etiology. And if you have an APE2 score which is greater than 7, it has 100% specificity of diagnosing an autoimmune process. So if you look at the score, it is just what we were talking about, new onset rapidly progressive mental status change within 1 year of evaluation. So for this, they have made it more than 3 months. You can wait for up to a year. New onset autonomic dysfunction, labile blood pressure, hyperhidrosis, asystole, ventricular tachycardia, neuropsychiatric symptoms, all get 1 point each. History of underlying malignancy within 5 years before the onset would get 2 points. Viral prodromal illness would get 2 points. FBDS will get 3 points because they are so characteristic. And focal dyskinesia in the absence of FBDS gets 2 points. So even if you have a focal dyskinesia, think of it. A hemidyskinesia or dyskinesia affecting only one limb. Seizures which are refractory to 2 or more AEDs, 2 points. CSF showing inflammation, 2 points. And MRI changes showing 2 points. So it's not difficult to get a 7. And if you get a 7, you need not wait for the antibodies and you could initiate therapy. Now, once you initiate therapy, if your patient has a RITE-2 score, and the RITE-2 score is nothing but an APE2 plus the presence of autoantibody, and you have initiated treatment within 6 months of onset. So really, while you send out the antibodies, don't wait for starting the treatment. Start with the milder treatments like methylprednisolone and immunoglobulin, whichever you think, or plasmapheresis. Typically at AIIMS we start plasmapheresis with methylprednisolone rather than just giving immunoglobulin, because once you've given immunoglobulins, you really have to wait for a good amount of time before you can initiate other therapies. So RITE-2 score, so both the scores have 7 cutoff, has a sensitivity of 88% and 84% towards a favorable outcome. So it's good to prognosticate your patients right in the front with the RITE-2 score. And we do make it a habit of initiating these scores when the patient comes in with us. So there has been an algorithm for predicting autoimmune epilepsy, and this is by Divyanshu Dubey et al., who's done a lot of work from Mayo Clinic. As you can see here, the division starts with this, clinical symptoms, but if the APE2 score is greater than 4 and you have done the antibody and you have autoimmune antibody and you're still suspecting autoimmune epilepsy, you would then divide them into score 4 to 6 and score more than 7. If the score is more than 7, obviously your diagnosis becomes probable autoimmune epilepsy. If your score is 4 to 6, it becomes possible autoimmune epilepsy. So it's good to write all this in the patient's file. Now we found that we could be helped by doing additional tests, not just the serum tests. We looked sequentially at our nuclear imaging, which gave us the right to write this paper that should APE scores be modified based on the metabolic topography of patterns which we find in patients with autoimmune encephalitis. So while we are waiting for the antibodies, you could do a ASL or you could do a PET, where you will find hot basal ganglia and you will find this frontal hypermetabolism, which was pretty typical in our patients and which resolves following therapy. As you can see, a hot mesial temporal, we are waiting for the antibodies, and hot mesial occipital, and you started them on steroids and plasma before the antibody reports came. And the patient actually had a LGI1 antibody positive when the antibodies came. By then we had finished 2 weeks of immunomodulation. So you could take the help of doing nuclear imaging, and this is another case which we reported where we had LGI1 which presented with just myoclonic jerks and confusion with hot basal ganglia. So please do go ahead. Even in the MOG epilepsy syndrome, we had a patient who presented with typical Rasmussen's-like picture, continuous EPC. And when you did the PET, there was this MRI showed this insular and mesial temporal hyperintensities and flare, and the PET showed a unilateral hypermetabolism. So here again, you could use nuclear imaging. And how did this improve the yield? In our paper, we found in the seronegative group, that is in whom you are thinking of a possible autoimmune encephalitis, MRI alone was diagnostic in 57%, but when you added PET FDG, it increased the yield to 77%. So it's upping it by about 20%. And among the 17 MRI negative patients, PET was diagnostic in 47%. So wherever you had a positive MRI, it upped the yield by 22%. And wherever you had a normal MRI, it picked up in 47%. So really, a combination of a metabolic topography on the nuclear imaging along with the seronegative case could increase the yield to about 71%. How do you manage these patients? You have to give immunotherapy, and we are very familiar with IV-MPS. At our center, we give IV-MPS along with PLEX, not to waste time. We usually give in a period of 4 to 6 weeks to show an improvement. So we do not say it's a treatment failure. We wait for about 4 to 6 weeks. If by the end of 6 weeks the patient has not improved or worsened, we definitely initiate the second line agents, which are rituximab, which is our favorite, and in some patients cyclophosphamide, in some mycophenolate, particularly if they are not able to come back again and again for the injections and they're from very far away. And I think we've used azathioprine only in one patient. We really don't like azathioprine, and we do maintain it for about a year in the NMDA and for lesser in the VGKC. So basically, the third line agent, which is bortezomib, we have used just in one patient. She was a doctor from Shillong. And tocilizumab, we have used again in only 2 patients. So third line agents are reserved till the very end, and these are to be used in patients who are not even responding to the second line agents. Now, you could just continue with repeated IVIG trials. So there are paradigms which have been published by Divyanshu Dubey, where they have given periodic IVIG, and you can see there 3 days, 6 weeks, repeat itself. So a combination of IVIG with IV-MPS can be used periodically if you don't want to give rituximab or cyclophosphamide. About rituximab, there's enough evidence with 277 patients, and about 47% of them had not responded to the first line therapies, and that's why rituximab had to be initiated. And it shortens the time to recovery and reduces the relapse rate. So tocilizumab is another agent which improved the MRS scores. As you can see, 91% patients have received it till 2020. I'm sure many more have. And bortezomib has been tried in case reports, and there was a dramatic improvement, particularly in the cognitive scores. Now, duration of immunotherapy is another very common question. There's insufficient data as to how long you should give the response till about 6 weeks. At our center, we tend to maintain for a year, particularly for the NMDA, because it has a tendency to relapse. Whereas for the LGI1 and Casper, we tend to taper the immunotherapy as soon as the patient is back to normal, and believe me, they return to normal pretty quickly. There is a Mayo standardized approach which is known as the 3 M's of treatment. That is, we should try to maximize reversibility of the seizures, maintain the reversibility with minimal therapeutic dosage. So we do have patients where we have tapered who tend to have a behavioral syndrome after we have tapered and tried to stop it. So we have to maintain them on a minimum amount. And right now we have a patient with Hashimoto's admitted who's come actually from Madhya Pradesh. And he just needs 5 milligram of a steroid with MMF. We are currently just discharging him. So just give a minimal therapeutic dose of maintenance. So basically the approach should be to overrule diagnosis of a malignancy, to overrule a diagnosis of any infection like herpes, then make a diagnosis of definite, probable or possible autoimmune etiology, and once you have done that, go aggressively with the therapy even while you're waiting for the reports. Wait for 6 weeks, and if they don't respond, go on to the second line, and if they don't respond within a month of starting the second line, go on to the third line agents. With this I conclude, and if there are any queries, we could take them.
Thank you, ma'am, for this talk. Now I invite Dr. CM Singh. CM Singh for presenting the clinical cases of epilepsy. Welcome, sir.
Everyone, starting with the few cases of epilepsy, and thank you Dr. Sanju Sharma sir for permitting me and allowing me to do this in such a knowledgeable and esteemed audience in front of. So I am trying to present 2 cases of epilepsy, and briefly I'll be focusing more on the semiology and clinically that how diagnosis of epilepsy was made, or just semiology wise how we can come to some conclusion or some rare variant. So starting for the first case, he is a 45-year-old gentleman, executive class, he is an officer, doing government job, and presented with complaint of recurrent He presented with a complaint of recurrent seizure, and that was since 2019, so pretty long history. Since last 3 years he was having recurrent seizure, and when he presented, that time he had 2 episodes of seizure, and I'll be saying the semiology also. There was no history of chronic illness like head injury or alcoholism or addiction, and there was no significant family history except for the father had significant cardiac illness for which he was taking treatment. So he came with two episodes of seizure. The first one, it goes like this, that he was in the bathroom and he noted vertiginous sensation. He thought that I am going to fall, and he shouted for the help. And when wife came, maybe after say around 20-30 seconds after that, she saw that he was lying in the floor with uprolling of eyeball and tonic posting of all 4 limbs, and very brief jerking of all 4 limbs was also noted. Post-ictally, he said that I had ringing sensation and fullness in both ears, and I was having a smell, very bad smell of some gutter-like smell or some bad mud-like sensation I had that persisted for a long time, and it was not associated with tongue bite, frothing or incontinence. And in further episodes also, in this episode also, there was no evidence of any oral automatism or manual automatism or ictal palsy or aphasia. Post-ictal aphasia was also not there, and no history of post-ictal nose wiping. The second semiology was, this was the first semiology, first episode which he had, and in later on also he had various episodes of such semiology. The second semiology was brief episodes of lightheadedness and flopping of head to one side without salivation or perspiration that lasted for say around 10 to 20 seconds, and immediately he used to regain the consciousness. So these 2 semiology he had. When he came for the first time with these 2 seizure, one was the brief seizure in the car, which was the semiology 2, and the first when it was in the bathroom, when the wife noted that. So if we go clinically, we can classify it definitely the complex partial seizure, and in view of some vertiginous sensation and some sensation of bad smell-like feel in the post-ictal period, okay, definitely neocortical temporal is the one localization which we can think of, but lateralization was not sure because history was not suggestive of any lateralization to either side. So he was referred from a cardiologist. He went to the cardiologist first because he had, his father had some cardiac illness, so he thought that maybe I had something. He went there to the cardiologist, and cardiologist evaluated for the everything, and he did the ECG. ECG showed right bundle branch block. He did all the LFT, RFT, calcium, sodium, potassium, everything he did. TFT he did. And he showed that okay, everything is normal. Echocardiography is also normal. No HOCM, no MVP. Go ahead. So you don't have anything which is just like your father. Go to the neurologist. You are having some seizure disorder, most probably. So definitely when he came for the first time with those 2 episodes of seizure, that was the first visit. I also thought, okay, yes, why not? It is a neocortical temporal, nothing to do with. Go ahead with EEG and get one some spikes, interictal spikes. Let's see. And then I got nothing. I went for one 3 Tesla epilepsy protocol MRI to look for the neocortical temporal. Something is there. He told no, nothing. It is normal. But then I was stuck. But yes, clinical is the one. So I thought it is neocortical temporal, and he started him on 1000 milligram of levetiracetam, and he was seizure free for the 8 to 9 months. Then again after 8 to 9 months, with the same 1000 milligram of levetiracetam, he had again episodes at the gap of 1 week in 2020. And this time also he had several episodes in bathroom, and some episodes either when he is traveling or doing some talks or attending some meetings, flopping of head to one side, and after that some feeling of some sensation that something guttery feeling, that mud-like feeling is there. So when he came and overnight video EEG was also done, did not show any, around 12-hour video EEG was done, did not show any interepileptic form discharges, and definitely the event was also not recorded because it was very infrequent, 3 to 4 episodes, one episode in 3 to 4 months, like that. So the possibility was, okay, he was 70 kg, 72 kg, maybe AED is not optimized, so go ahead with 2000 mg, gradually height up to the 15 milligram and then 2000 milligram of the levetiracetam. But the wife was very eager to say about this thing. He gets all these episodes in the bathroom only. I have never seen in his office time or in driver or car time, but in bathroom he spends 30 minutes to take bath. He takes very ritualistic bath. I said, okay, what is that bath? He narrated it like that. 10 minutes I take bath with the hot water, nothing happens. 10 minutes with the soap, I use very particular brand he likes, and he says I am very fascinated for that. Even if I go abroad, I take this soap and take the aroma of that, and then I thought, okay, now I am going to be clean. So he had some fancy about this thing. And then 10 minutes of the cold water. So Doc Sahab, it takes around 30 minutes to take bath for me, and most of the time I don't get anything. But sometime I remember after 30 minutes of the bath, when I am mopping and all, then I remember something has gone wrong, I shout, and then I remember, oh, that guttery feeling, again it has come. So what is that? I want to get rid of that smell, that is why I have come to you. Otherwise I am doing fine, I have nothing abnormality. So my question was, which type of phenomenology I am dealing with? Is it some kind of reflex epilepsy, bathing epilepsy? No, because it is not on the hot immersion or water is coming down and immediately he is getting. He is getting in the last phase of the bath, in fact, after the bath. So should I add on some other anti-epileptic, because 2000 is fairly good enough? Or should I repeat MRI with focus on the temporal region? So question was, all those questions were there with me. But he asked me some question over phone one night, and that question was, which center is best for pacemaker implantation for me? So the thing was how the history evolved, that he himself noted that while walking in the treadmill, he had another episode. He went to the third and the fourth stage, and he noted that again that feeling of fall or something is going to happen, and he called the wife, and then he revisited the cardiologist, and cardiologist found that, okay, you had 2:1 AV block, prolonged Holter monitoring was done, and PPY was done, and maybe in March or April that permanent pacemaker implantation was done, and now since last 5 months he is asymptomatic, and levetiracetam has been reduced to 500 mg per day. So how the things went wrong? Actually, all the phenomena, that the smell sensation, that the ear sensation, all were after the seizure. Actually, it was not aura of that vertiginous sensation which he was saying over. It was just the lightheadedness and tendency to fall, feeling of tendency to fall over. It was just like some premonitory symptoms. And the another thing was, it was very brief. None of the episode lasted for more than 1 minute. So it
it was mostly related to the arrhythmia induced some convulsion or the motor manifestation and the autonomic manifestation, and predominantly the motor manifestation of the syncope was more the autonomic manifestation, that smell sensation, with that was basically more trouble. So there is, I will just, because I have to go for the another case also, so I will brief the review of the literature. So there is basically the whole domain. This is neurocardiology, not only the stress leading to the cardiac problem or the brain, but there is some suggestion of definitely in the sympathetic overdrive and epilepsy. The epilepsy is very closely related with the arrhythmias and other things. There is a sub-classification of arrhythmogenic seizure also. So, as you already know, the sinus tachycardia is the most frequently observed arrhythmia in patients with epilepsy, up to 60 to 80%, 100%. And ready arrhythmias are less observed, even in less than 5% of the seizure. And ready arrhythmias, which are classically seen, are sinus bradycardia, AV block, and prolonged AV systole. Ictal bradyarrhythmias have substantial morbidity because of their sudden loss of consciousness, which may lead to the falls and traumatic injury. And there are some suggestions of the lobe involvement also, according to the arrhythmias, which are, although it's not very concrete, but there are some suggestions of the lobes also, that temporal lobe epilepsy has been more related to the bradyarrhythmia, and it is less associated with the frontal regions. And the pathology or the pathophysiology is like seizure-related stimulation of certain brain regions such as insular cortex, amygdala, and hypothalamus, which interfere with the autonomic control of the heart by a connection with the autonomic nuclei of the brainstem and spinal cord. Even the lateralization of the foci related to the tachycardia is also described. Like seizure originating from the left hemisphere usually have the ictal bradyarrhythmia, whereas the ictal tachycardia is more associated with the right hemisphere, but it's not always true. This is the hypothesis in some suggestion or in some of the literature it is there. So that was the first case. Another case, very brief case, 15-year-old boy presented with the complaint of history of recurrent seizure from 12-year phase. He was born by full-term normal delivery, but there was meconium and there was history of parental hypoxia was there. Little bit of cognition and motor milestone were delayed, but he was doing fine. He was 8th or 8th standard student and doing average in this time. So the history of recurrent seizure from 12-year phase, and the semiology was like aura in the form of heaviness of head and pulling sensation in the head. Ictus was in the form of head and eye indication to the right side, salivation from the mouth followed by coughing, post-ictal vomiting and mild confusion for 5 to 10 seconds, and it is also very brief duration lasting for mainly 20 to 30 seconds. And for this fellow, all episodes, they occurred while eating only, and it used to occur at 3 to 4 times a day, especially in lunch or breakfast time when he takes lot of food. MRI is showing that there is T2 hyperintensity in the perisylvian area. If we see the EEG showing the discharges with the phase reversal centrotemporal discharges are there, left temporal centrotemporal discharges are there, and this is the video. So this is the video with which the relative came, and it is the eating epilepsy. So there is a bit confusion. He started the food, coughing, and then that's all, very brief. And after that he takes his feed, and so it is definitely, now that was not the case, but here yes, it is a reflex epilepsy, that is the eating epilepsy, and it is one of the very rare reflex epilepsy. Predominantly the report is there from the
Sri Lanka, but Indian study also is there, in which they reported around 12 to 14 cases of eating epilepsy. And what the classical seizures usually precipitate during first few minutes of a meal because of the proprioceptive sensory stimuli from the complex lingual, buccal and pharyngeal movements. And these sensory stimuli lead to the recruitment of the epileptologic neurons, triggering a critical mass of cortex to precipitate seizure. So 75% of patients in the Indian study had perisylvan electrographic or neuroimagic localization. That's just like in our patient also. So, the response to the treatment for this eating epilepsy usually it varies, but they respond very well with the clobazam, that is half an hour before 5 mg or 10 mg if we give, and mostly they respond very well. But in Sri Lankan study they have found that it is usually resistant type of epilepsy, and our patient, after eating clobazam in the morning and the night time before the meals, after half an hour, that was significantly reduced. That's all. Thank you. So one is the neurocardiology and another is the neurogastroenterology maybe. Thank you.
House is open for question and answer session, please.
Joy, any expert comment on ictal bradycardia or AV block presenting as or Manjari for that matter? Whether it was aura or a seizure.
So there can be a bidirectional relationship, that is a cardiac problem inducing a convulsive syncope or a seizure, both. Or it could be a seizure which then goes on to produce a ictal cardiac issue which could border on to just mild tachycardia to even tachyarrhythmia to even cardiac systole. So both these are known. And what is important is to, whenever we do a ECG or even a video EG where we want to capture events, one should have a ECG channel along with the EG channels programmed in. And wherever you suspect that the symptoms are atypical related to posture or activity, like in this patient the focal seizure was happening when he was bathing, and maybe the temperature issues were there, or maybe he was standing for a long time while bathing. So always try to do an ictal recording with the ECG to capture the phenomenon, so that the treatment would be different here. You would have to put a pacing here, and sometimes even in a seizure where there is ictal rhythm abnormality of the heart, you may have to put in a pacemaker. So you will have to have a team with the cardiologist to manage it. However, mild abnormalities like heart rate variability, just tachycardia, are very known very well in seizures. So I think Dr. Sanjeev has published a case report about the same. Yeah, Dr. Sanjeev. Yeah.
No. Brugada may not have, it may have various kinds, including heart block. So I think this is Brugada syndrome because father also had similar problem. You just read about it, it will fit into Brugada syndrome. Okay.
Thank you. So it's a Brugada syndrome.
Hello. Now all the chairperson, Dr. Ashish Mittal sir, Dr. Priyanka Kashyap ma'am, please give away the memento to the speaker. Dr. Joy Desai sir, Dr. Shripat Pujari sir, Dr. Suvarna Aladi ma'am, Dr. Manjari Tripathi ma'am, Dr. CM Singh sir. Please come on the dais. Hello. 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 Shripat sir, please give the memento to the chairperson. Thank you, sir. Thank you, ma'am. Now the session 2 will be started. I will like to call upon the chairperson, Dr. J.S. Katpal sir, Dr. Shailendra sir on the dais. Dr. Katpal sir.
Yeah, good morning to all of you. It's my proud privilege that I've been invited as a chairperson along with Dr. Katpal to this Chhattisgarh and MP cgcom. The first speaker of this session is Dr. Satish Kadilkar. He does not need any introduction. He himself is a legend. He was a past president of the Indian Academy of Neurology, and presently he is a senior consultant at the Bombay Hospital, as well as he is the dean of the Medical College, Bombay Hospital, I think the Mumbai, Medical College, Mumbai. His talk is the neurotherapeutics in the field of the muscular dystrophy. May I request Dr. Satish Kadilkar to give a talk on the neurotherapeutics in the field of the muscular dystrophies. Kadilkar sir, please.
Sir, in this newer talk, I hope it's an ongoing of what we are hearing for a number of years कि हनुमान जी आएंगे जड़ी बूटियां लेके आएंगे और सारी बीमारियां ठीक कर देंगे. Because we have been very much optimistic about so many research papers and talks and things of that kind. But eventually, so far, nothing great has happened. Years back, when I was talking to one of my friends in Northwestern University, Chicago, when they were doing a lot of work on genetic treatment of gliomas, and they spent number of years, they said, no, we are not successful so far, we have not attained much. Similarly, Dr. Manjari Tripathi will also agree that on epilepsy, this talk is going on for a number of years, that there will be one gene study, one diagnostic test for epilepsy, one treatment, and anyway, but we should listen to Dr. Satish Kadilkar, what he has to say about the newer treatment in the muscular dystrophies, and then we'll discuss it after. Thank you.
Good morning, everyone. Firstly, let me thank Sanjay and Nachiket for asking me to be here. I was going to make this comment in the end, but I'll start with the comment. Dr. Kakulas, with whom I spent some time, who's no more this year, used to say that we want to treat diseases that we have not understood. And I think it's a very, very appropriate comment. I mean, there are suffering individuals, and therefore we want to help them, and therefore we want to treat them, but we haven't understood the diseases. And that's one of the reasons why we are never reaching the point that quickly, because we don't understand them, we don't know what obstacles will come, and that's why the process is very long. Right. So, right, so let's start. So how many minutes do I have? So please stop me when my time is up, because there is a lot that I have put in.
20 minutes. 20 minutes.
How many?
20.
Oh, good. Yeah, that's good. Right. So let's start with the most common disease, Duchenne muscular dystrophy. All over the world, for some reason, the prevalence and incidence is the same. Again, something that's very hard to understand. Whichever population you take, it's 1 in 3,500 approximately live male births. And we know that the children start falling and they can't run, and they have lordosis and calf hypertrophy and ankle contractures. And we also know that it's a very large gene, 79 exons with hotspots, 80% deletions, 10% duplications, remaining point mutations. And I think luckily, since the private players have come into genetics in India, even point mutations you can easily characterize now. So genetic characterization of Duchenne dystrophy is not a problem anymore in India. Now let's quickly go to the reading frame hypothesis, because I think that's the basis of the gene therapies. The reading frame hypothesis is that when there is a deletion, some part of the gene has gone away. If the remaining parts join well, that's the in-frame mutation. So whatever is remaining, if it joins, it creates a protein that has at least some meaning. If the parts on two sides of the deletion cannot approximate well, then no protein is created. So here you see the 79 exons, so to say. In between you have a large deletion, but the parts will join, and therefore you will get a Becker. And below you see a small deletion where the reading frame has changed, so the protein will be useless. So another example for this one could give is, you have say the sentence, "You can see the boy." If the D is dropped, you can see boy. Still a meaningful sentence, still a meaningful protein, you will get Becker. Now, reading frame hypothesis holds good in about 90% of Duchenne and Becker cases. So this is the basis of why the new gene therapies, or how the new gene therapies have been designed. Now, before going to the gene therapies, let me also just give an overview of what's available. Corticosteroid, cell-based strategies, gene-based strategies, and exon skipping. These are the four big categories under which you will talk about diseases applicable to Duchenne and Becker, and I'm sure to other dystrophies as well. I want to make a comment about corticosteroids. I know that it's not a new therapy or anything, but I think anecdotes are always interesting. When I newly joined Bombay Hospital after the training, Dr. Darab Dastur, whom some of you have known, was a great pathologist. And we were lucky to be able to interact with him for long hours actually. So when a Duchenne dystrophy biopsy will be sent to him, he will say, he will find the inflammatory cells. And he will make a comment, corticosteroids may be used. This is way before corticosteroids were shown to be effective in Duchenne muscular dystrophy. And those of you who have seen him with his shock of white hair and a phenomenal personality, he would go up and talk to the patient and then tell me, I still had black hair at that time, why don't you give steroids? And it became so difficult for me to say, okay, look sir, it's not standard of care at the moment. But 10 years later, it's standard of care. We all use steroids. How many of us are enamored with the use of steroids in Duchenne? I don't know. I'm not particularly enamored, but it does seem to do something for a certain period of time before they go down. Now with that little anecdote, let's go on to where the gene therapy is. The use of antisense oligonucleotides. Just to refresh the memory, antisense oligonucleotides or AONs are small molecules that can alter a protein production. They are single-stranded parts of a DNA that match the mRNA, and therefore they can modify or destroy a protein. So this has been pictorially demonstrated in this slide. You have the DNA converted to mRNA, the messenger RNA. That's the turquoise color. And then an ASO joins that mRNA or sits on a part of that mRNA, binds to that mRNA and modifies the mRNA. It's a small molecule, which is again a single strand of DNA. And here you see, on the left you see the ASO sitting on an mRNA. And the protein that is converted changes because it changes the properties of the mRNA. And on the right you see it sits at a place like an out of frame mutation where it doesn't allow any protein to be synthesized. Now this concept is very potent because you can modify a protein that is generated. So loss of function mutations also you can change. And you can also destroy a protein synthesis, so a gain of function can also be handled. So in that sense, it's a very potent concept. So all the developments are in the field of ASOs, and different ASOs doing different things. The first one to come, first player in the game is eteplirsen, which works for exon 50 deletion. Now various populations show percentage of 5 to 10% of exon 50 deletion. I think it is smaller based on some 2000 some consecutive patients. It's smaller. So eteplirsen is applicable in a small number of patients where there is a single deletion of exon 50. Also let me make a comment that when you see a single exon deletion in a report, please have it double checked from some lab that you trust because technical errors are also there. So right, so here is how eteplirsen works. The 50 is already gone. So 49, 51, 52 don't match. It's an out of frame mutation. And the patient gets Duchenne dystrophy. Eteplirsen sits on the 51. So now the deletion is effectively converted into 50 plus 51 by masking of the exon. So now 49 will come close to 52, which is an in-frame mutation. So eteplirsen converts an out-of-frame deletion into an in-frame deletion, and therefore the patient is supposed to have a milder phenotype. So in 2016 it got approved and it has been used on people in some countries, which is an intravenous weekly infusion of 30 mg per kg or 50 mg per kg. It goes on for 22 weeks. Just to abreast you of the problems, like we say, we started off by saying that we treat diseases that we don't know. How do you judge an outcome? You're given this to the patient. Your outcome is a 6-minute walk test in this first eteplirsen trial. And second is dystrophin in the muscle. Now, most of us do the 6-minute walk test in the consulting room. You have a 4-year-old boy and you expect that every time he will put in his 100% to walk 6 minutes. Oh, it's just not on. Someday he wants a chocolate, someday he doesn't feel like running. And you're going to base your results on a test as flimsy as a 6-minute walk test. That's one problem. The second is you want to show that the dystrophin content has increased. Now you've taken a biopsy from somewhere. You can't take the biopsy from the same spot again, you've already taken it. So you're using some other muscle. And we know that the dystrophin, quantitative dystrophin estimation of different muscles in a Duchenne boy is different. So there is an assessment issue here, clinical as well as in the lab. So there are various trials, and there are these issues that I have lined out. If someone wants to read about it, this is one very good article where the drug design, development and therapy all has been given at one go. The second drug is atallurine, which is also an antisense oligonucleotide, and it works on nonsense mutation. It targets the premature stop codon. So again, I think the cartoon will explain it better. That's the normal stop codon at the top. In a Duchenne patient, there is a premature stop codon, therefore an incomplete protein. Atallurine facilitates the translation and the functioning protein increases. So this works again on a certain category of patients with DMD, which again are not many. So just like etiplursin for a few, atallurine also for a few others. For exon skipping strategies, there are still more agents now, depending on which single exon is gone. So 51 was etiplursin, 45 is casimersin, and exon 53 also has viltolarsen. So up to this point, what has been achieved is single exon deletions at certain points can be handled. Their phenotypes can be made milder by using the ASOs. Then I think the mini dystrophin, the next approach is by giving mini dystrophin through a AAV and then hoping that it works. It is not as yet as successful as that. And whenever you do not have a good medicine, there are dozens that are in trial. So all these are under trial. From Duchenne, let's move to limb girdle. Again, the strategies are similar. Send a vector or use an ASO. But in LGMDs, they are not as successful as yet as in Duchenne. Duchenne naturally being the commonest. But it will be good to know that there are multiple trials going on about various ASOs and various AAVs in various types of limb girdles. And you need not go into the details of that. None of them is as yet by the bedside. Now let me make a comment on where are we in India. It's very nice to read that these things are done for some patients and see the photos that patients have become better. But really, where are we today? Our first problem is to get ASOs at our cost in our country. So there are 3 or 4 places in the country where ASO production locally is already begun, and I think 1 or 2 places are at a point where they will be able to commercially supply the ASOs in a short period of time. If that happens, the cost of the ASO will be much less because there's patenting and all the other issues. But as things stand, the cost of therapy is way out of reach for anyone. And there are litigations already in the court of law again and again that why my son who has a deletion of 50 cannot get etiplursin. So when you look at where does the evidence stand? It's 14 patients, 8 patients, 20 patients. So really the evidence of the benefit of the ASOs worldwide as yet has not reached a point where our government can really say, okay, even though expensive, this should be used. So it's at that point at the moment. I'll make a few comments about the stem cell therapy because this is something that every patient asks me. I'm sure he asks shall I go and get it done? And a lot of them get done. So basically, I think scientifically, the properties of transplantable mononuclear cells in the muscles should be the following 3. They should have a capacity to incorporate their nuclei into the myofiber of the receiver. They should have a capacity to form new functional myofibers after the nuclei have gone there. And they should also then originate a pool of the mononuclear cells, which are like the satellite cells of the stem cells. So again, this cartoon shows it. You have given the blue cells, which are the good cells. The reddish looking cells are the Duchenne cells. So once they go, they must incorporate the middle picture. They must incorporate, they must form a new myotube, which is a good tube. And they must also sit there when next thing is needed. So most of the experiments with stem cell at the moment does not fulfill these three criteria. So really it is not possible at the moment for stem cells to regenerate and give you good muscle, even though in future that may be one of the ways. And I'll quote one very interesting experiment. This was done in Bombay about 5 years ago. It was a patient-funded research. The patient's relatives, parents of patients with Duchenne, funded the project, and we got mesenchymal stem cells from the fat. The plastic people were doing the liposuctions. We got stem cells from that. There are lots of stem cells in the liposuction material, and then we processed them, and you could create dystrophin-producing cells by converting blasts from the liposuction material into myoblasts. This green thing is the dystrophin, and blue is the good nucleus. So initially with much efforts, and then second and third time not with so much efforts, in a Petri dish you can create good cells from liposuction. And if our center in Bombay could do it, I'm sure any center can do it. The problem is those cells don't last in the body. You put them, body kills them. So they have to be first on steroids, still doesn't help. So I think stem cell overall is still a dream, but someday it may. After doing Duchenne, Becker, and then limb girdle, and then talking a little bit about stem cell, let me just run through these slides where therapies are available. They're not necessarily very new therapies, but I think we should remind everyone of that. One is, of course, Pompe disease. One comment I want to make, that every Pompe disease does not reflect in the biopsy. So at one time it was the biopsy and the past staining, but the enzyme and the gene, whenever you suspect, you need to do, and I think 3 to 4% of all LGMD collections are non-LGMDs, and one of them is the Pompe disease. And Myozyme is available free now. Myotonias do get better with mexiletine, some with acetazolamide, and we had a couple of published families with pyridostigmine. You can use steroids when the FSHD patient goes down quickly for a certain period of time. Another comment I want to make is, please don't miss the CMS. It looks like a limb girdle dystrophy. Many of them look like a limb girdle dystrophy, and they're so eminently treatable. Lots of treatments available. A lot of other metabolic myopathies like Cori disease, McArdle disease, carnitine palmitoyl acetyltransferase deficiency, other neutral lipid storage diseases are amenable to lifestyle and certain medications, so we need to keep them in mind. And of course, mitochondrial myopathies we all like, but there isn't any great evidence that they get better, but most of us use the mitochondrial cocktail. Right. So that's in brief about where we are. Of course, it is like a ethereal at the moment. It may be somewhere for tomorrow, but not at the moment in our hands. But I think worth knowing at the moment. So again, coming back, we're trying to treat diseases that we have not understood. And I think we have to understand them better to really know what strategies we will. Also, let me lastly touch upon, we had the whole session on immunology and neurology, immune epilepsies, immune encephalitis, everything. You know, the boundary between immunological abnormality and genetic defect is not watertight. Just like Duchenne gets cells, LGMDs get cells. There's a whole set of limb-girdle muscular dystrophies with a known genetic defect that have cells. There are PMP22 protein deletions that have cells in the muscle. So I think our traditional thinking that there are genetic diseases and there are immune diseases, I think they're not watertight compartments. I'm sure there are immune counterparts to or immune processes activated in an abnormal way in so-called genetic diseases. But again, we come back to the same point, we haven't understood it well enough as yet. So, thank you very much. Questions now or in the end? Thank you.
Now may I invite Dr. Sumit Singh. He is a consultant in the New Delhi. There is a hospital, Artemis Hospital, Gurgaon. He is one of the topper. He is a very academician of the All India Institute of New Delhi. And his primary area of the interest is movement disorder. May I request Dr. Sumit Singh, please. Dr. Sumit, please. Can we make up the time with Dr. Sumit Singh is not available. Diabetes in neurology, Dr. Anita Nambiar from Kochi. Dr. Anita, please.
A very good morning to all of you. Thank you, Sanjay, and the whole team for this invite. It's a pleasure and honor to be here. I'm back to Raipur after 31 years. I did my post-graduation from Pandit Jaina Medical College in 1991. So, thank you again. Next 18 minutes or so, I will be talking on diabetes and neurology, nothing related to neurology. It's just the drugs that is there in the armamentarium, especially the new drugs, and how it can give some neuroprotection. So, as per the ICMR India DIAB study, which has come 2 months back, it is India has got 101 million diabetic patients, and the prevalence is around 11.4%. And we know that diabetes is the cause for increased macrovascular and macrovascular mortality. And also, they are at high risk of cognitive impairment and also developing Alzheimer's disease as well as dementia. So the most important thing is 90% of the diabetic patients, they are taken care by primary health center physicians, and few lucky people, they go to secondary and tertiary centers. So it's very important that all of us being in medical profession who are medical graduate, they should know how to treat diabetes, because next 3 to 4 decades from now, we are going to have epidemic of diabetes. So the cardiologist has become very wiser. They have started using GLP-1 agonist and SGLT2, and they are treating almost all the diabetic patients that go to them. Having said that, let me begin my talk. So when I did my graduation and post-graduation, we were told that hyperglycemia occurs because of 3 things. One is decreased insulin secretion, second is increased insulin resistance, and third, increased output of glucose from the liver cells. Now the scenario has changed. We know the ominous octet by DeFranco, and also the egregious 11, where there is 11 pathways. And now there are 15 to 16 ways, pathophysiological ways, how hyperglycemia can occur. Why I'm saying this is because drugs targeting different aspects of this octet are being developed and employed in the treatment. So it means few of the subclinical and translational trials, they have shown the molecules or metabolites which are responsible for developing diabetes. So if we can target those things and we can develop few drugs, I think in days to come, we will have less complications which is associated with diabetes. And most of the time we talk about this octet only. I won't go into the detail. Till 2-3 years back, we were mainly actually concentrating on how to reduce HbA1c. That was our goal. Reduction in HbA1c was the most important thing while treating a diabetic patient. Now it has gone from a glycemic-centric algorithm to complication-centric algorithm. So what is complication-centric algorithm? We know as per ADA, and also American Association of Clinical Endocrinologists and Research Society for Studies of Diabetes in India. Nowadays, when the patient of diabetes, they come to us, when we examine, at the end of examination and complete examination and biochemical parameters, we have to divide the patient as high risk for atherosclerosis, cardiovascular disease, or heart failure, stroke, CKD, or none. And we have to treat them according to the complication that we expect or they already have. So for those patients who has got ASCVD or high risk of ASCVD, we have to start the patient on GLP-1 receptor agonist or SGLT2. And for heart patient, failure patient, it is SGLT2. For stroke and TIA, we have got GLP agonist and pioglitazone. For CKD, we have SGLT2 or GLP one receptor agonist. That doesn't mean that we don't have to bring down the blood sugar to the normal we have. If there is no complication, and we don't expect any complication in that patient, we have to start them on drugs. The patient is on metformin, we have to continue that. If HbA1c is above the goal, if 7.5%, we have to start 2 drugs. If it is more than 9, we have to start on 3 drugs. And if it's more than 10, we really have to start the patient on insulin. And now the glucose-centric algorithm. This too has changed. We have to see how the patient is, what is his build, whether the patient is able to afford medication, or does he has hyperglycemia or hypoglycemia, what are the risks like. So these are the things that has to be taken. So apart from the lifestyle modification that we need to make them understand about the importance of lifestyle modification, and the first drug of choice is definitely metformin. And then if the patient is overweight and obese, we have to start the patients on a GLA receptor agonist or a SGLT2. And we have to avoid sulfonylureas in such patients because they are going to have more of weight gain during the treatment. If the patient is prone to hypoglycemia, we have to start them again on GLP-1 receptor agonist or SGLT2. And again, we have to avoid sulfonylureas in such patients. If the cost is a factor, if the patient is coming from a poor background, we have to start the patient on thiazolidinediones and sulfonylureas, and we see to that the patient do not, it means we do not prescribe GLP agonist because it's really costly. Of course, SGLT2 and all drugs have become cheaper and if the patient has got severe hyperglycemia, again we have to start the patient on insulin, and we have to keep on adding one by one drug till we achieve it. Now these are the drugs which are available in our armamentarium for diabetic management, and I am not going to go through any of this. And sulfonylureas, there were many ifs and buts, but the CVOT trial has come, Carmelina and Carolina, which has showed the safety of glimepiride. So the second and third generation, and out of this, the best is glyclazide and glimepiride. And I'm skipping metformin. I don't think I will talk about metformin. So the 3 important drugs that I'm going to talk is thiazolidinediones, GLP-1 agonist, a short briefing about DPP-4 inhibitors, and then SGLT2 inhibitors. So we know thiazolidinediones, one of the best drug which has got pleiotropic effect, but because of some reasons, it went out of market in 2010, but the ADA RSSDI guidelines again says that it is one of the best drugs if used judiciously. So it acts primarily by decreasing in insulin resistance. It does work by activation of PPARY, it modifies the gene and expression of transcription and decreases lipolysis-free fatty acid, inflammatory markers, increase adiponectin, and improve insulin sensitivity. As I said, there was some concerns regarding its cardiovascular problems because it has the tendency for fluid retention, sometimes congestive cardiac failure, bladder cancer. And all this bladder cancer and everything in the new review, they have said it has got nothing to do with bladder cancer, but it is one of the drugs that can be used judiciously, keeping the dosage between 50 to 30. Now, there have been few CVOT with cardiovascular outcome trials with pioglitazone, and the first one is proactive trial, which showed significantly, the pioglitazone significantly reduced the risk of secondary macrovascular event in a very high risk patient population who had established macrovascular disease. Now the IRIS trial, this is the important trial, and here the importance of secondary prevention in patients with stroke and transient ischemia was studied, and it showed that it was effective in secondary prevention of stroke in patients with diabetes and who already had a stroke and transient ischemic attack. The third one is a Chicago trial, which showed that there was slowing of progression of carotid intermedia thickness compared with glimepiride when pioglitazone was used with that. And the periscope trial, it also shows the lower rate of progression of coronary atherosclerosis. We know atherosclerosis is one of the most important factor for causing so many things when a neurology field is concerned. Then we had the TOSCA-A trial, which showed pioglitazone offers long-term CV safety with 5 years of follow-up. Now, what are the mechanisms of stroke risk and poor stroke outcome in diabetic patients? So we know that is hyperglycemia and there is insulin resistance, there is endothelial dysfunction, increased reactive oxygen species, nitric oxide signaling is decreased in such patient leading to atherosclerosis and thrombosis. And when there is systemic inflammation because of increased insulin resistance, there is increased pro-inflammatory cytokines and decreased adiponectin, all leading to higher stroke risk, poor outcome, increased stroke injury size, and neuroplasticity. So if we target the mechanistic underpinning of endothelial dysfunction and inflammation in diabetic patients, actually we can restore neuroresilience mechanism to improve outcome following stroke for diabetic patients. Now coming to the most important things of today's talk, that is development of promising agents. So we have, as a complement to the standard care approach, we have two important drugs in the armamentarium. One is SGLT2 inhibitors, which had shown the reduction in hospitalization for heart failure and slowed renal function decline, and which has profoundly changed the treatment paradigm for the diabetic and also non-diabetic patients at high risk for cardiovascular or renal disease. And then we had incretins, GLP-1 agonist. Again, it has demonstrated pleiotropic benefit in patients with ASCVD and those with ASCVD risk. These have shown to reduce the MACE and cardiovascular death to same degree of patients. DPP-4 inhibitors has been proven to be cardiovascular safe. We have sitagliptin, linagliptin, and all gliptins which have undergone CVOT trials. From 2008, the FDA has made it mandatory that all new drugs for the treatment of diabetes should undergo a CVOT trial. Now the incretin effect, we know that there are two gut-derived factors. One is GLP-1 and the second is GIP. These are gut-derived factors that increases glucose-stimulated insulin secretion. And we have got, I said, GLP-1 and GIP. Both are secreted from the intestine in response to glucose level from ingestion of food, and increase the release of insulin in response to meal. So the function of GLP hormone, this reduces appetite, slows gastric peristalsis as well as emptying. It increases the expression of GLUT4. It inhibits glucagon release, less intense glucose release from glycogen, and enhanced proliferation of beta cells, and there is increased glucose-dependent insulin release, thus decreasing glycemia. So again, this action of incretin is for very short time and short life, 1 to 2 minutes for GLP-1, and for GIP it is the T-half is 7 minutes. So if you can block these agents with the inhibitor, the half-life will be increased. So this is the treatment option where we inhibit this, and the active GIP and GLP will act at the level of pancreas, brain, stomach, and liver. So what are the positive things about GLP-1 receptor agonist? At the level of brain, it increases synaptic transmission, nerve protection, it increases memory, proliferation of neural stem cells, and also helps to improve the motor function and signal level of satiety. At the same time, it decreases memory impairment and neuroinflammation. And it has got various effects at the level of liver, pancreas, GI tract, and heart as well. So how does this occur? So how the neuroprotection occurs with the help of GLP-1 receptor agonist. So at the level, there is increase in synaptic plasticity, there is decreased in cerebral inflammation, decreased AGE, and I think I cannot see it here, where I came. Yeah, and oxidative stress is decreased, microcirculation infarct volume is decreased, there is decreased amyloid plaques, and there is more of neural growth. And what does it help? It helps in decreasing cerebral atherosclerosis, and the direct effect is a decrease in improved endothelial function and increase in nitric oxide. There is less of vascular smooth cell proliferation, vascular inflammation is decreased, and there is decreased lipid accumulation in the cells. And the indirect effect through this is there is decrease in blood pressure, decrease in weight, and decreased HbA1c. So how the neuroprotection occurs in patients with diabetes. So if this is the algorithm how to go for neuroprotection with GLP receptor agonist. So if the patient has got type 2 diabetes, a prior stroke, or there is TIA or high risk for stroke, independent of HbA1c baseline, if the patient is on DPP4 inhibitors, we have to stop DPP4 and add on GLP-1 receptor agonist. If patient is not on DPP4, we have to start directly on GLP-1 receptor agonist. If the patient was already on sulfonylureas and insulin, if the HbA1c is more than 8, there is no dose adjustment required. If the patient has got HbA1c less than 8, then we have to cut down insulin by 20% and sulfonylureas by 50%. So this is another way how GLP-1 receptor agonists they are. Coming to the drug which has changed treatment scenario in diabetes, this is SGLT2, sodium glucose transport 2 inhibitors. So we know that in the normal glucose homeostasis, what happens is there is glucose filtration through the glomerular, it is filtered, and 90% of the glucose that is reabsorbed in the proximal tubule, and also 10% by SGLT1. So approximately 160 to 180 gram glucose is filtered from the glomerulus and reabsorbed into the blood circulation, and no urinary glucose excretion is observed in such things. Now in diabetic patients, around 180 to 240 grams of glucose reaches glomerular filtration per day. This level is very high. So when the renal threshold is beyond 180, there is glucosuria, and this is how we do SGLT2 inhibitors. They help in decreasing the blood sugar level. So this is the mechanism of action. We have DAPA, EMPA, canagliflozin, atogliflozin, and sotagliflozin. Sota is SGLT1 and 2 inhibitors. Cana has majority of SGLT2 and minor SGLT1. So this causes diuresis, natriuresis, glucosuria, uricosuric, as a result of which there is decreased preload and afterload, there is decrease in systolic blood pressure, arterial stiffness is decreased, volume is decreased, body weight is decreased, hyperglycemia reduced, glucose toxicity, and insulin resistance. These all are required to prevent atherosclerosis as well as to improve cardiac function in patients with diabetes. So the indication is both in non-albuminuric kidney disease, non-diabetic, and type 2 diabetic albuminuric disease, and heart failure with reduced ejection fraction, and type 2 diabetes with hyperglycemia. Okay. So what are the benefits of SGLT2 inhibitors? Type 2 diabetes, there is decrease in HbA1c, there is major MACE are reduced, hospitalization for heart failure is reduced, and decrease in CV events, especially deaths. And there is, as far as kidneys are concerned, there is decreased need for dialysis, the EGFR improves. And we have number of trials with SGLT2 inhibitors. We had EMPEROR trial, we have Emperor trial, we have ME trial, we have EMPA heart, EMPA kidney, and so many means trials are coming. So how the atheroprotective and neuroprotective effects of SGLT2 happens. So I think this is such a small. So SGLT2 inhibitors, they decrease glucotoxicity, inflammation, and they increase BDNF, that is brain-derived neurotropic factor, decreases intima, carotid intima media thickness, there is decrease in oxidative stress, the circadian rhythm of mTOR is maintained, and this causes, so it has got two sort of protection. One is atherosclerotic, atheroprotective effect, and the second is possible neuroprotective effect. So it increases the polarization of M2 macrophages, and the attraction and adhesion of monocytes are decreased. There is endothelial dysfunction, remodeling is decreased, it decreases blood pressure, it decreases BMI. So that's the way how it gives atheroprotection. While talking about the neuroprotective effect, it decreases neurovascular remodeling, senile plaques are decreased, there is increased growth, survival, plasticity of neurons, and ischemia, perfusion damage is decreased. So this is, and this improves the cognitive functions. So these are the places where SGLT2 and SGLT1 receptors are placed, and in brain it is more of SGLT1 compared to SGLT2. All these areas, I am sure all the neurologists are pakka in their knowledge. And so this is how it happens when there is brain damage, the SGLT expression is increased, which leads to more of volume of the infarct size in case of stroke. And when we give SGLT2 and 1 inhibitors, it acts the same way. And actually, this causes increase in lesion size, inflammation, ischemic area, the cognitive function is decreased, neuronal death is also increased. When we block the receptors, that results in the lesion size is decreased, inflammation is decreased, the perfusion damage is decreased, neuronal cell death is increased, and there is increase in cognitive function. So there are side effects of SGLT2, which I need not talk. So to summarize, diabetic mellitus is an entity of considerable morbidity comprising a spectrum of multi-system dysfunction stemming from combination of resistance and inadequate insulin resistance secretion, and 2/3 of the patients, they need more than one oral agent. There is a perpetually increased newer range of anti-diabetic drugs targeting novel aspect of diabetes, which warrant adequate awareness by the treating clinician. So those in secondary, so when I talk, pioglitazones, they are used especially when we are treating secondary, prevention of secondary stroke. GLP-1 agonist for primary prevention. The stroke guideline says that GLP-1 agonist can be used, and the guidelines, I think it has incorporated GLP-1 receptor agonist. SGLT2, though it was not included, but nowadays it is included because it has means many actions, many way of action by which it will give a neuroprotection. Thank you very much for the kind attention. Thank you, Sanjay, for calling me here. Thank you. Any questions, if I can answer, will answer.
Any specific question? Otherwise, can we ask during the lunch time with the speaker? Can I invite the second speaker, Dr. Sumit? He's from the Artemis Hospital from New Delhi. He's going to speak on the headache management to the current millennium. Dr. Sumit, please, sir.
Good evening. A very good morning to all of you, and thanks to the organizers for giving me this opportunity of speaking in this event. How do you? And it's not getting displayed.
Dr. Sumit has spoken on headaches many times to us at various platforms, but he'll be showing us also today some non-pharmacological tactics of relieving headaches, both the acute headache and the chronic headache. And apart from that, I'm sure he's going to tell us about newer drugs which are being used in the headaches in any case.
ये तो खुल गया, उधर नहीं आ रहा, इस पे वही नहीं आ रहा तुम्हारा. अच्छा, डिस्प्ले नहीं हो रहा ना?
नहीं हो जाएगा.
Okay. Okay, so regardless, so neurologists have been borrowing drugs from cardiologists, from epileptologists, from pain medicine people. There were very few actually direct innovative ideas and innovative substances available specifically for the treatment of migraine. So over the last decade or so, there has been an explosion in headache medicine, and the understanding of the pathophysiology of migraine has changed almost completely. The targets of treatment have changed almost completely, and therefore the medical options which are available to us have also changed almost very, very significantly. So I have certain disclosures, and I'll be flowing through the overview of migraine and its pathophysiology, the acute treatment options, what is new, the migraine prophylaxis, particularly the role of anti-CGRP, and then a word about neuromodulation, which is the new in thing. It is important to understand the cycle of migraine because all these aspects carry a different connotation in terms of their pathophysiology. For example, the aura part is because of cortical spreading depression probably. The headache is because of extensive vasodilatation which happens after a phase of vasoconstriction. And then the postdrome is because of the fatigue which happens in these patients with migraine. If you look at the pathophysiology of migraine, then in a genetically predisposed individuals, in response to certain triggers in the environment, there is release of certain chemical mediators of inflammation inside the brain, which includes prostacyclines, prostaglandins, calcitonin gene-related peptide, the factors for platelet aggregation. This causes vasodilatation, and it also causes a sterile neurovascular inflammation of the trigeminal system, which causes actually the headache. It is important to understand the role of CGRP in migraine because CGRP is very widely distributed inside the brain and also in the GI system, and therefore it is probably now being considered as central to the causation of migraine. It is an inflammatory protein which initiates and propagates the headache, and the CGRP receptors are very widely present in the pain sensitive structures of the brain, which is the meningeal blood vessels, the nociceptive trigeminal nerves, and apart from this, it is also present extensively in the trigeminal ganglion and the sphenopalatine ganglion, apart from being present in almost every organ of the body. Also, it's important to understand the interaction between serotonin receptors and migraine. So 5-hydroxytryptamine 1B and 1D receptors are in the intracranial blood vessels, mainly the meningeal arteries. These are potent vasoconstrictors, I mean the drugs which act on these drugs, the agonists. In contrast to this, 5-hydroxytryptamine 1F, it modifies the pain transmission through the trigeminal caudalis nucleus. It inhibits the release of chemical mediators of inflammation and has almost and the agonists which act on these receptors have a very different mechanism of action in the acute treatment of migraine. So in order to summate this pathophysiology, there is a neurogenic inflammation which is happening inside the brain, which causes peripheral and central sensitization, which is perceived at the level of thalamus as pain and localized at the level of the cortex as an exact site for the headache. Now, the treatment of migraine would be in these three broad headings. So it would be acute treatment, preventive treatment, and then non-pharmacological interventions. So acute treatment is probably the only treatment which is required if the headaches are too few or too infrequent. The intervention has to be done at the onset of the pain, not at its peak, because if you take the painkiller or the migraine specific medication at the peak of headache, it is probably not going to work so well. There is also transient gastroparesis which happens during an attack of migraine, and therefore a prokinetic might be better to be administered with these drugs. Now, what are the drugs which we have in our armamentarium? So there are all these types of triptans which have various routes of administration. Some of them are oral, some of them are nasal sprays, some of them are in the form of orally dispersible tablets. Then we have a very old and a very favorite of many, Vasograin and Argets. There might be a combination which might be required in form of non-steroidal anti-inflammatory drugs alone or in combination with domperidone. These we are all very familiar with. The new kids on the block are the GPANTs and the DTANs. So these are the two new drugs which are in the process of being brought over in the headache management guidelines of our country. If you look at the evidence, then there is a level A evidence for all types of triptans. There is evolving evidence for the use of GPANTs and DTANs in the management of acute attack of migraine, apart from ergots, non-steroidals. And then we have level B evidence for antiemetics, antidopaminergic drugs, and other opioids and barbiturates as an escape form in severe migraine when the first line drugs don't work. Now the symptoms will help us in deciding what is to be given. If a patient is having too much vomiting, then probably a nasal spray or an oral dissolving tablet might be a good option, but otherwise oral drugs in the form of tablets can be given to those patients who do not have nausea. Unfortunately, injectable somatriptan which was available in India is no more available now. Triptans are headache-specific medications, and thankfully they have been there for almost 2 decades. But our comfort zone with triptans has never been to that extent that we write it as the first treatment for migraine. We still love our non-steroidal anti-inflammatory drugs a lot. There are several types of triptans which are available to us. The assessment criteria for the efficacy of migraine is in these headings. So all the trials which have evaluated triptans look for headache relief at 2 hours, headache freedom at 2 hours, sustained pain relief at 2 hours in 2 out of 3 headaches, pain freedom at 2 hours in 2 out of 3 headaches, the most bothersome symptom of migraine. And this is the meta-analysis of 25 trials done by Michel Ferrari, in which more than 3,500 patients were evaluated, and the summation of almost all these criteria showed that probably rizatriptan and elmotriptan are the drugs which are the ones which probably not directly comparable, but probably are the best suited drugs for treating an acute attack of migraine. All these triptans are more similar than different. So the one triptan which you like is actually the best one for your patient. The important thing is when to give. So early intervention at the end of the aura phase and the beginning of the headache phase is the time when you have to give these triptans. Patients who have coronary artery disease or cerebrovascular disorders, those who have uncontrolled hypertension, pregnant ladies and complicated migraine are relative contraindications for triptans, and this is what is the unmet clinical need for an acute treatment of migraine, where the new drugs come into play. So though triptans are considered as gold standard, there are specific contraindications. They are ineffective in as high as 40% of individuals, and those patients who fail the initial treatment with triptan are more likely to go into opioids and more likely to go into medication overuse headaches. These triptans cannot be given in older individuals, cannot be given in disorders of the cerebrovascular nature or in the coronaries when they are involved. It cannot be given in patients who have renal issues, cannot be given in pregnant and breastfeeding ladies. So lasmiditan is the new kid on the block. It is going to be available very soon in India. It is the first FDA approved drug available in 50, 100 and 200 milligram alloquots. and it is a 5-hydroxytryptamine 1F agonist, and that's what I told you, that this is not a vasoconstrictor, this is an anti-molecule which decreases the release of chemical mediators of inflammation inside the blood vessels. Important safety concerns with lasmiditan is that it can cause serotonin syndrome, so it has to be given with the care in patients who are on SSRIs, and it has a mild abuse potential. If you look at the clinical evidence, then there are at least 2 phase 2 trials, at least 4 phase 3 trials, and a meta-analysis of these randomized controlled trials. So the most important ones are the Samurai and the Spartan trial, which together have evaluated more than 5,000 individuals. And in both these trials, in the Samurai study, where 100 and 200 milligrams of lasmiditan was found to be far superior to placebo and active placebo, and also in the Spartan trial where similar evaluations were found. In a meta-analysis of these trials, the primary safety endpoints, it was found that the brain freedom at 2 hours and complete freedom from pain was also better in the lasmiditan group as compared to the placebos. The most common side effects which are there with lasmiditan are dizziness, somnolence, and fatigue. There is a caveat which comes with the lasmiditan, that if a person is on lasmiditan, then he is preferably not allowed to drive. When we compare them with triptans, then the difference between them is predominantly that while the triptans act on the blood vessels, the ditans, they act on the trigeminal pathway. And they are not vasoconstrictors, and they do cross the blood-brain barrier at ease. So they act both at the peripheral sensitization and the central sensitization in the migraine causation pathway. So if we compare the 3, that is the gepants, the ditans, and the triptans, then if you look at the efficacy, probably the triptans might be the best. If you look at the side effects, then the gepants might be the worst. And if we look at the overall efficacy and safety profile, then probably the ditans might be the best. So those patients who are old, those patients who have cerebrovascular, cardiovascular comorbidities, those patients who have complicated types of migraine, probably ditans would be the drugs which can be given to these patients. Now, what's new in the field of preventive aspects of migraine? We all know that migraine prevention is extremely important, because if we don't prevent migraine, then there is a possibility of these patients to be turned into medication overuse headache and chronic migraine, which is a nightmare even for headache specialists to take care of. Our target for preventive treatment would be to reduce the attack frequency, severity, and duration, and also it is important that we prevent the conversion of episodic migraine to chronic migraine and medication overuse headache. Now, evaluation of several thousands of patients has been found that the main reason why people discontinue their prophylactics is because either they are not effective, or they have too many side effects, or they have compliance issues. So they hate taking medicines on a regular basis. Despite being a troublesome disorder, most patients would say, "Doctor, ye dawai kab tak leni padegi?" And roz ek goli khani padti hai. That is one thing which is probably the most important factor why people leave prophylactics, why they abuse painkillers, and they convert into chronic migraines and eventually medication overuse headaches. So the drugs which are available to us, we are all familiar with these. I am not going to talk about them. Over a period of time, in various trials, it has been found that the jugular venous samples have been found to be having very high levels of cGRP during an acute attack of migraine, and therefore today cGRP is evolving as central to the causation of migraine in most migraine models. It can be associated with vasodilatation, cortical spreading depression, nociceptive activation, central sensitization, and that is why probably its role is being targeted too much. So there are 2 types of anti-CGRP molecules which would be available today. So one would be one which acts on the CGRP receptor. So it blocks the CGRP receptor, but the available CGRP is free to bind with other receptors and other targets. On the other hand, we have those molecules which are directly acting on the CGRP ligand. So the CGRP receptor is vacant and many other molecules which might interact with it be available. So the one which is acting on the CGRP receptor is available in India and it is erinumab. The ones which act on the CGRP molecules are eptinezumab, framinezumab and galcanezumab. Very shortly there is a possibility that galcanezumab might also be available with us in India. So the first drug to be approved for the prophylaxis of migraine amongst the anti-CGRP molecules was erinumab, and this is there are studies for the use of erinumab in chronic migraine, in episodic migraine, in patients who have chronic migraine with medication overuse headache, and then there are studies which have been open label studies to look at the efficacy and safety of this drug for over 5 years. And in all these studies, while the baseline characteristics of both the treatment and the placebo arm are similar, there is a very clear indication that there is a significant reduction in a monthly migraine days from baseline to week 12 in patients who received erinumab as compared to the comparator. And it was seen that 70 milligrams per month as a subcutaneous injection is almost as effective as 140 milligrams of monthly injections. The requirement for acute migraine specific medication was also significantly better in the erinumab group as compared to the placebo. It has been found to have a sustained efficacy in chronic migraine over a period of 1 year. So once a month injection is something which is quite acceptable to these patients. It has also been evaluated in a similar fashion in patients with episodic migraine with almost similar results. It has found similar efficacy in patients who have migraine of a chronic nature with medication overuse. And overall safety in all these trials has been excellent. And the only major side effect which has been found in these patients is a gastrointestinal discomfort and constipation. In my experience, I've found that probably the constipation in Indian patients is a little more than what has been reported in the literatures. So this is an open label evaluation of these patients over a 5-year period, and the exposure adjusted patient incidence rate of constipation was lower as compared to the open label phase. So the constipation and local site reaction, these are the only problems which are there with the anti-CGRP injections. So in summing up, the safety profile of erinumab is quite good. The acceptability of the drug is excellent. The efficacy is proven, and this is something which probably is going to be the present treatment for migraine in case affordability is not an issue. There are other drugs also. All of them have been evaluated in very good trials, and they have been approved by FDA. The good part is that the galcanezumab is one which can be given in 3 monthly injection instead of monthly injection. So all these 4 drugs have been evaluated and have been found to be effective in patients with migraine. Now, what are the long-term effects? We don't know, because actually you don't know what you don't know. And there is a possibility that over a period of time we might find our own set of complications and problems with anti-CGRP molecules. But considering today, in terms of safety profile and efficacy, probably these drugs score over the ones which are available as yet for us. Neuromodulation is a new thing which is coming up in the management of migraine. So transcutaneous magnetic stimulation, repeated transcutaneous magnetic stimulation is something which is not available in India as yet. But the next 2 devices, that is the Cephali and the transcutaneous peripheral stimulation, is available in India. And a pharma company is coming up with this molecule. So this is Nerivio. So this is Nerivio Mitra. This is available today in India. Is going to be available in India today. So this is a simple device which you bind over your arm in the mid-arm stimulation area. There is an app which you download from the App Store or the Play Store. You connect this device to your smartphone, and on your smartphone you just start its stimulation and you continue with the stimulation for about 45 minutes, depending upon when you achieve the pain freedom. So there are two ways of using it. You can use it on a SOS basis when you have an acute attack of migraine, and this is basically licensed for 15 uses. So once you buy this device, which is going to cost around 14,000 to 15,000 rupees, you can use this device 15 times, and after that you have to take the license again, or you have to pay again to renew your license. In patients who have chronic migraine, there are trials in which it has been used as prophylaxis also, in which you use it every alternate day. So you have a month's therapy once you use it every alternate day, 15 times in a month for prophylaxis of patients who have chronic migraine. In terms of trial, it has actually found numerically as good efficacy as oral pharmacotherapy, and it has been found to be as good as Botox in patients with the chronic migraine. So what to give, whom to give in patients with migraine is a thing which you will probably learn over your experience. There is no one shoe which fits all. There is no blanket treatment. But in the present era, the triptans, detans and gpans can be used for an acute treatment. You have a drug which is usable in practically all the population. So in young individuals, you can use triptans. In older individuals, you can use the detans. In those patients whom you can't give triptans, you can give detans. Neuromodulation is coming up in a big way, but the good part with neuromodulation is that it does not have any side effect at all, apart from some local irritation or temperature rising when you bind this Nerevio device. Anti-CGRP antibodies, except for the cost, might eventually be the drugs of choice for migraine management because of the ease of administration, the frequency of administration of once a month to once in 3 months, and almost complete lack of side effects apart from local irritation and constipation. But of course, those patients who can't afford this, a rational therapy is in the form of available medications can be used. So if one has to draw an algorithm for the treatment of migraine, then there would be two aspects. One in which only acute treatment is required. One should most usually start with a non-steroidal. It could be your favorite acetaminophen, it could be aspirin, it could be brufen, it could be anything which the patient is comfortable. If the patient has too much of a nausea, then adding a domperidone might be worthwhile. If the patients do not respond to 3 consecutive attacks of migraine with these non-steroidals, then a triptan might be tried, and over a future course, if those patients who cannot be given a triptan or cannot tolerate a triptan or do not respond to 3 consecutive trials of triptans, then we have availability of detans today and maybe gpans tomorrow. In those patients who have 2 or more severe migraine attacks, or those patients who have prolonged attacks, or those patients who have a complicated migraine, prophylaxis of migraine is absolutely essential. And we have antihypertensives in forms of various forms of beta blockers. We have anticonvulsants. We have amitriptyline. We have flunarizine and other calcium channel blockers. In those patients who have chronic migraine, we have botulinum toxin injections and greater occipital nerve blocks. So we have an entire buffet in which you can be creative and choose your own set of medication and combinations. But those patients who have a failure to drugs, those people who can afford, or those patients who have significant side effects, anti-CGRP molecules will be probably the treatment of today and probably tomorrow. So with this, I end my presentation. Thank you for your very kind listening, and this is my invitation for you for the annual conference of the Neurocritical Care Society of India, which we are organizing in the month of September end to October 2nd in Western Gurgaon. Thank you very much again.
So thank you very much, all the speakers, for a wonderful session which we had. And of course, Dr. Sumit Singh for a good emphasis on kind of the treatment which are being used for headaches. It's a long subject. It's a very personal issue. The consultant choice matters, the patient's taste matters, everything. There are so many things involved in the treatment of headaches, but it is not so simple. It's a very serious affair to treat headaches. There are today hospitals available in many countries where they are treating only headaches because they have to be hospitalized. The headaches are so bad. Anyway, let's conclude this session.
The chairperson, Dr. J.S. Katpal sir and Dr. Shailendra Jain sir, please give away the memento to the speaker, Dr. Satish sir, Dr. Sumit sir, Dr. Anita ma'am. Dr. Satish sir, Dr. Sumit sir and Dr. Anita ma'am, please give the memento to Dr. J.S. Katpal sir and Dr. Shailendra sir. Now I will like to call upon Dr. Gagandeep sir. He is the president of Indian Academy of Neurology. To cheer up this session, I will like to call upon Dr. Nachiket sir, Dr. C.M. Singh sir.
ये हो गया लोकल डिस्क में ये रहा ये इसको कॉपी करना है डेस्कटॉप में कैसे आएगा यस सर एलिस का इसमें ये वाला फोल्डर इसमें ये लगा हुआ इसमें लगा
Good afternoon, dear friends, colleagues, and seniors. It's my pleasure to introduce Dr. Gagandeep Singh. He is amongst us, and we have the pleasure of listening to him. He will be delivering his president's oration. I invite him for the same. Thank you.
It's not showing. Can anyone help me? Right. Yes, it is. Right. So at the outset, thank you, Sanjay and entire team for getting me over to Raipur once again. It is always such a pleasure. Friends, those of you who don't know that Sanjay and me, we train together and we have lots and lots of good memories to share always. And Sanjay actually asked me to talk on microlepsy, which is a very, very focused kind of subject area. Nevertheless, I thought I'll try, and this is my opening slide, and you can see a whole lot of papers, titles here, right? I mean, the subject of all of these papers is migralepsy, and if you look at the titles, they're all, is it migralepsy? No evidence as yet. Is it migralepsy? Still don't know. I mean, is migralepsy a concept at all? Is there a definition for migralepsy? Is there something like migralepsy? So all of these papers bring forth the entire controversy to mind as to, is there something known as migralepsy, if at all it exists, and what is it? Just by the way, the current IHS classification, it's not labeled as migralepsy, it is labeled as migraine aura triggered seizure, right? So that's the current classification. So when there is a controversy, and this is a lovely photo I made today morning from my room, and when things are not clear, it's always good to look at the forest and not the trees. So let's talk a little about migraine, let's talk a little about epilepsy, and then we'll come to migralepsy. So we all know that Sumit had a wonderful talk, he's already not here in the hall, on migraine, and we all know that epilepsy and migraine are extremely common. There are about 50 million people with epilepsy in the world. That means 1 out of 26 persons in the world has epilepsy. Nearly twice, migraine is twice as common as epilepsy, so 1 in 8 people have migraine. And then if you look at the frequency, incidence or prevalence of migraine in people with epilepsy, and there are studies which have looked into this, the incidence and prevalence of migraine is increased amongst people with epilepsy. And likewise, there are studies, though not very recent, which have clearly shown that the incidence of epilepsy is increased amongst people who have migraine, right? So there is a shared link. What might be the basis of this shared link? It's that there are cases which are extremely rare, monogenic disorders like familial hemiplegic migraine, CADASIL. There might be a shared genetic risk. And just by the way, most of the migraines and most of the epilepsies are not monogenic disorders, right? They're not single gene disorders. They are polygenic disorders. That means there are hundreds to thousands of genes with very small effects which add up and contribute, and eventually the patient or the person manifests with either seizures and likewise for migraine. So they are both polygenic disorders and they are not monogenic disorders, and that is why genetic testing is done in epilepsy, is done in migraine, but to a very small extent, right? So there is this concept of shared genetic susceptibility, and indeed there are a number of studies which have looked at shared genetics of migraine and epilepsy, where people with epilepsy have an increased risk of family members having migraine, and people with migraine have an increased chances of their family members having epilepsy. So those kind of studies also are there. There might be a direct causality, and then we'll come to that, and I'll show you some instances where migraine might be the consequence of seizures or vice versa, right? And last but not the least is they could just be, it's pure coincidence, so it's just two common disorders occurring in the same person. So this is what I actually spoke about, the genetics of both migraine and epilepsy. Extremely heritable disorder. Twin studies have shown that up to 30 to 60% of people with migraine have a positive family history of migraine, and I spoke about the nature of inheritance. And there are issues like familial hemiplegic migraine, which I will actually go on to talk about migralepsy. So first, epilepsy. And this is a very characteristic syndrome. I'll show you this video. home video. It's not very common. Gastro syndrome occurs typically in children between about 8 or 9 years of age. There is a positive family history, and these children have very characteristic seizures. It is actually in the differential diagnosis of benign occipital lobe epilepsy, also known as the Panayotopoulos syndrome. So this, in comparison to Panayotopoulos syndrome, is a little difficult to control, but it eventually also remits, right? And this is all that happens during the seizure. There is gaze shifting towards one side for a few seconds, and that's all that happens during the seizure. But if you ask the child, and this child actually drew this picture here, and this is what he sees, right? And this is typically an epileptic visual aura. What's an epileptic visual aura? How do you see that? Look at this. This is another pictographic demonstration. Colored spots, multiple colors, red, blue, green, yellow, right? They appear and then they just disappear. So this is a very characteristic visual aura arising from the occipital lobe. Of course, as you go anteriorly towards the temporal lobe, the temporo-occipital junction, you can start getting formed visual sensations. But a typical elementary visual aura arising from the occipital lobe in people with epilepsy, who they might have a structural occipital lobe lesion, or it might be benign occipital lobe epilepsy or the Gastro syndrome like this, are typical colored dots and shapes in a particular visual field, which come in for a very short period of time, and then they just disappear. Or certain patients might actually again have this kind of colored, multicolored or single colored shapes, and they may actually move horizontally. And this horizontal movement is very typical of an epileptic visual aura, right? What happens in migraine? So we know that the pathophysiological or the electrophysiological basis of migraine is, migraine aura is a cortical spreading depression which progresses at the rate of 3 millimeters per second and usually starts in the occipital lobe, and that's why you have a visual aura, and then it spreads anteriorly. When it spreads more anteriorly, it gives out to a somatosensory aura. More anteriorly, it involves the motor area, giving rise to hemiparesis. More anteriorly, it involves the speech area, giving rise to an aphasic aura. So this is the way the cortical spreading depression or a migraine aura progresses from posterior to anterior, and as it progresses from posterior to anterior, it can lead on to a typical visual aura, it can lead on to a somatosensory aura, it can lead on to hemiparesis, and then eventually an aphasic aura. Visual aura is obviously the commonest, but you can have patients who have a somatosensory, hemiparetic, or an aphasic aura as well, right? Now this is a classical appearance of a visual aura. Let me see. Right. So just look at this. Usually it begins in the center, sometimes it might begin eccentrically as a bright or a black spot, right? And then it gradually increases in size. The periphery of the aura is scintillating and has zigzag lines. Can you make out that zigzag lines? Right? And then it gradually keeps on increasing in size, forms a crescent like this, and as it increases in size, the center starts clearing up, right? And you can see the scintillating scotomas and the multicolored zigzag lines in the periphery. And then it eventually disappears. And this process, as opposed to an epileptic visual aura, which usually lasts for a few seconds, this one lasts for about 10 to 15 to 20 minutes, right? So the difference between a visual aura in migraine and a visual aura in someone who has epilepsy is very much there and is very easy to pick up, right? So you have these historical descriptions, and the one on my right is by the Airy brothers, the father and son. George Airy was the British royal astronomer in the 18th century. And he actually drew these auras and described these scintillating scotomas, and this is from his drawings. He had typical auras without migraine. I mean, he didn't have the headaches. And remember, about 5% of people might just have the aura and not the migraine, right? So this is known as typical aura. Quite often these patients would have migraine with an aura in their childhood, early life, but as they grow older, they just have the typical aura and not the headaches, right? So there is a whole lot of differential diagnosis, whether it is epilepsy, whether it is a TIA or whatever. But if you look at the history, the typical description, the evolution of the aura, and the history of migraine in childhood, I think the diagnosis can be very certain, and you really don't need to go into a number of esoteric investigations in order to make a diagnosis of typical aura without migraine. So some of the terminologies. So phosphine is just a phenomenon of light entering the eye without actually light being there. So how do you experience phosphines? Just close your eyes and press on the eye, and you will experience some light-like sensation. So that's a phosphine. Photopsiae are bright flashes of light in a visual field. Tecopsiae is that typical, can you see that zigzag kind of border which is very luminous in someone with migraine? And the fortification spectra is actually, the term is derived from the medieval European buildings or forts, where you can see these kind of fortifications at the edge of the migraine, and that is known as fortification spectra. Scintillating scotoma is just a bright spot which shimmers between dark and light, right? And then you have conditions which I think Sanjay would describe, Alice in Wonderland syndrome, where people or parts of people or parts of objects might actually grow very big or small. They might appear very far or might appear very near, or they might actually change shape, known as metamorphosia. So these are diagrams, and what I do in the clinic is I have a set of color pencils in my diagram, and someone comes with a visual aura. I give them a piece of paper and ask them to actually draw what they see. And mind you, they always end up drawing it. I send them to the other room. I meanwhile see another patient, come back to them after 15 minutes, and they come up with these drawings. And this is the drawings made by one of the patients who had typical aura without migraine. She didn't have headaches, she just had the typical aura. And these are the times, so 1:33, 1:34 is 1:34 p.m. and 35 p.m. Every minute, how did the aura actually evolve and then eventually disappeared. So asking them to draw is extremely important, and that can give you important clues to the diagnosis. This is another patient who I asked him to draw, and this is what he said, and he said, I start off with the same feeling as if I'm looking into my mother-in-law's eye, right? So that is what he described the migrainous aura. So this is a tabulated form of differentiation between a migrainous aura and an epileptic aura. We've all discussed this. And with this background, Alice in Wonderland, Sanjay, I think you will talk about, so I'm not going to discuss this. And there are a number of other things which are there at the borderland. And you know, this is a description of a case which I found which was published in 1879 in the Lancet by William Gowers, right? and the description is very characteristic. So this patient had started seeing something very brilliant before him, and then he felt an extreme pain, and then he had these attacks almost daily. And when he used to walk, he felt that the road would become narrower, and then he generally could see better on the right side than on the left side, so he had a left homonymous heminopsia. He was then treated with bromides because that were the only anti-seizure medications which were available at that time, and the attack ceased. So Gowers felt that this was epileptic, but of course in the paper he discusses whether these attacks were epileptic or migrainous. And when the patient died, he had an autopsy, and the autopsy showed a tumor in the anterior occipital cortex. So you can have migraine-like attacks, auras which seem like epilepsy, followed by headache, right? And all of these are symptomatic of an underlying cerebral lesion, most often in the occipital cortex. And there is a beautiful case series by Gordon Plant and all in 2011, which describes symptomatic occipital lesions with epileptic type of visual auras and followed by headache, which is typical of migraine. So now coming to some of these terms, migralepsy, which is, as I said, the current term is migraine aura-triggered seizures. You can also have some other conditions like hemicrania epileptica, ictal headaches, and post-ictal headaches. So coming to post-ictal headaches, and I think it's extremely important while trying to understand what is migralepsy. Post-ictal headaches are extremely common. You know, it's just that we don't ask for them. In fact, this is one of the thesis of one of the students at our hospital institute, and he is asking all people who present with a seizure, a recent seizure, do you have headaches? And he tries to classify the headaches. He's trying to see whether the headaches fit into migraine or non-migrainous headaches. Is there a prior history of migraine? And he's also trying to see whether there is a family history of migraine in these people. And roughly, I mean, just an estimate, roughly about 50% of people, particularly those with generalized seizures, have a post-ictal headache, right? And there are criteria for post-ictal headaches. And if you tend to classify them, roughly about half of them would be migrainous and the other half would be tension-type headaches, right? So ictal headaches are actually extremely common. Post-ictal headaches. Ictal headaches is a different thing, where the headache actually occurs during the seizure. Usually it is in the context of non-convulsive seizures, sometimes non-convulsive status epilepticus, and then there is a term, hemicrania epileptica, where you have ipsilateral headaches. The headaches are ipsilateral to the epileptogenic focus, just lasts for seconds and minutes, and is actually a partial seizure. So this is something which is extremely rare. So now coming back to migraine epilepsy, and the current term is migraine aura-triggered seizures. There are two things which are extremely important in the definition. First, the patient should be having migraine with aura, right? Someone who doesn't have the aura will not have migralepsy, right? And the seizure usually occurs during or within 1 hour of the aura, right? So these are the two criteria according to the IHS, International Headache Society classification, current version 3, that the person should be having migraine with aura, and the second thing is the seizure should occur within 1 hour of the onset of the aura. The term migralepsy was coined by William Leno and in the 1960s, and this was one of the first textbooks of epilepsy, right? And in this textbook, he describes 3 patients with migralepsy. So this is the first historical description of migralepsy. So let's look at this case, and I would like to know what your views are about this particular case. Female, 16 years old. At onset, there is a typo, it's her field of vision, it's not field of vision, it's field of vision, more particularly the right side would be filled with yellow whirling stars, like driving through a snowstorm. Then she started feeling that she herself is growing smaller and more distant. Her thoughts appeared to be jumbled, and this was followed by loss of consciousness and a complex partial seizure. We don't use the term complex partial seizure nowadays, but I mean, if you were to analyze this history, what would you say? I would say this patient had epilepsy, right? And then there was a short-lived bilateral headache. So despite the fact that she had headache, I think she had epilepsy. And mind you, in the 1960s, there was no CT scan, there was no MRI, right? So when there was no MRI, there was no CT scan, how do you think they would have ruled out an occipital lobe lesion? They wouldn't have been able to rule out an occipital lobe lesion. So it's very likely that this 16-year-old girl had occipital lobe epilepsy. There could have been a structural lesion, we don't know. And if you go by the types of the visual aura that occurs in context of epilepsy and in context of migraine, I mean, I would say that this fits into an epileptic visual aura. She has occipital lobe epilepsy. She then feels herself growing smaller, so that's Alice in Wonderland syndrome, which Sanjay will explain, and then she becomes unconscious. So this is a typical, I think this is a typical occipital lobe seizure. It's not really migralepsy. I mean, you can call it migralepsy, but the description is very much like migralepsy, an occipital lobe seizure. Case 2, 25 male, flashes of red and blue round lights, principally in the right eye, could occur very frequently as once a week. A headache could follow. At times, the display of lights was followed by the appearance of a crowd of people rushing like a stampeding herd, and there was subsequently loss of consciousness in a generalized tonic-clonic seizure. Right? I mean, I would say this isn't just an occipital lobe seizure, going on into what we now call as bilateral tonic-clonic seizure. So focal to a bilateral tonic-clonic seizure. So, I mean, it is not without reason that many experts, and I showed you all those papers, and I'm showing them again, the titles, that many experts feel that the term migralepsy probably does not, is not there, it does not exist. It remains a controversy. You can rarely have seizures in context of migraine, and the current term, if at all you have to use a term, it is migraine or a triggered seizure. My take on it is I would certainly in such kind of situations rule out a structural lesion in the occipital cortex. No doubt that symptoms of migraine and epilepsy can sometimes lead to diagnostic confusion. This was commented on by Sir William Gowers in 1906 in his monograph, The Borderlands of Epilepsy, quote unquote, when the patient's account is all that we have to guide us, we must make a diagnosis from the general features of the case, not forgetting that one disease may unquestionably pass on to the other, and some attacks are clearly of intermediate nature. Thank you so much.
Thank you, sir, for wonderful presentation. The migraine associated with epilepsy and subsequently migralepsy. And since he mentioned about Alice in Wonderland, I would like to call upon Sanjay to share his thoughts here.
We just require a sound for a video. Otherwise, it's going to be a very futile exercise. This is a first case which I recorded of Alice in Wonderland, and we investigated this patient up to a particular extent, and there was a confusion whether it was a temporal lobe generated epilepsy or it's a case of headache with Alice in Wonderland syndrome. So seen by two experts, Professor J.M.K. Murthy did his epilepsy workup, which was not very suggestive of epilepsy, and then the child was looked after by Dr. Helen Cross also, and she opined that it's possibly Alice in Wonderland syndrome with a migraine. So there are only two things relevant once you talk about Alice in Wonderland syndrome. As the chapter 1 says, that she then discovered a bottle and the level labeled drink me, which causes her to shrink too small. And in chapter 2, this is a feature that Alice growing to such a tremendous size, her head hits the ceiling. Alice is unhappy and she cries. So that tells us this experience of aura or this Alice in Wonderland is not a pleasant syndrome. Child is always frightened, he is very fearful during this episode. There is no pleasant feeling attached to this. So this is a story of 9-year-old male, Arpit. He has episodes of a tremulousness of hand, unpleasant, frightening episodes of dizziness, and abnormal visual perception of becoming smaller and larger. Objects moving closer or far away. He feels like everything is falling and shrinking. He is growing in the size, at times becoming smaller. Episodes occur mostly in the evening, lasting for 30 to 45 minutes and preceded by a headache, followed by a vomiting once in a month. And what's more important, that the mother has a history of a migraine since 10 years.